friends and teachers, on behalf of Indian Pancreas Club, we welcome you to the third webinar of the webinar series of Indian Pancreas Club Pancreas 2020 and Evidence-Based Approach. We have had two webinars so far, the recordings of which are available currently on YouTube on our channel, the Indian Pancreas Club. We've had a very good response so far. We have almost 800 registrations and attendance has been pretty good. So today's webinar, I hand over to Dr. Pramod Garg to carry on with the proceedings for the day.
Thank you very much, Sudipta, for organizing this series of webinars. And this particular webinar is very interesting because we are going to discuss some topics which are clinically very relevant, and some of these topics are not often discussed. So I'm very happy that this seminar is being organized today under your able leadership. And we have a galaxy of speakers today. The first session will be on autoimmune pancreatitis, an entity which was described first time in Japan and later from other parts of the world. And now in India too, we see many of these patients. So I'm very happy that Professor Anil Arora has kindly agreed to chair this session. He's a very dear senior colleague of mine, and he's someone who has taught me right from the beginning when I joined BM Gastroenterology. And he's someone, despite being so busy in his practice, is always eager to teach and train people. So over to Professor Anil Arora for taking over for starting the proceedings of today's webinar. Professor Arora, please.
Thank you, Pramod, for excellent introduction. And first of all, let me at the outset pay my tribute to Professor Rakesh Tandon, who was the founder of the Indian Pancreatic Club. He had been such a good motivator, excellent clinician, and a researcher par excellence. I think his deficiency is very difficult to fulfill. And I'm sure Dr. Pramod is trying his best to fit into his large shoes. The first topic of presentation today is autoimmune pancreatitis, which by definition is a chronic steroid-responsive fibroinfiltrative disease of the pancreas. Even though the description goes back to 1960, with a typical case of non-alcoholic pancreatitis of inflammatory origin, which had presented in a similar fashion, it was only in 1995 that Yamada described this as one of the entities which was steroid responsive. After 6 years, Hamano told us that it was possibly related to IgG4 disease, and it took us another 11 years to come to a consensus classification, which is now very easily identifiable as type 1 and type 2 of autoimmune type of pancreatitis, which have distinct clinical features, distinct epidemiological patterns, as well as the clinical manifestations. To talk about the clinical manifestation, epidemiology, and the diagnosis, may I request my dear colleague, Professor Surinder Rana, to come and tell us about what autoimmune pancreatitis is. Dr. Surinder Rana, please.
Thank you so much, sir. Good evening, everyone. At the outset, I would like to thank the Indian Pancreas Club for inviting me and giving me this opportunity to participate in this excellent webinar series on various aspects of pancreatic diseases. And today I have been asked to speak on the epidemiology, clinical features, and diagnostic criteria of autoimmune pancreatitis, the introduction of which has been very aptly given by Professor Anil Arora. So is my screen visible?
Yes.
Okay. So as it has been told that it's a unique steroid responsive form of chronic pancreatitis with a characteristic histopathology and imaging. It is rarely encountered in clinical practice. It closely mimics pancreatic cancer. We know that it may either involve the pancreas diffusely, which is known as the diffuse form, or focally, which is a focal form of chronic pancreatitis. In the current era, where the availability of serum IgG4 assay is widely available, we also have to keep in mind that there is now an era of probably incorrect overdiagnosis. Hence, therefore, there is a need to accurately and correctly diagnose autoimmune pancreatitis. The first question is it truly an autoimmune disease? If we look at autoimmune pancreatitis, unlike most conventional autoimmune diseases, it's more common in males, whereas other autoimmune diseases are more common in females. And there is no universally accepted and validated target antigen despite almost 3 decades of extensive research in autoimmune pancreatitis. We see IgG4 positive plasma cells, but still we don't know what's the role of these cells in the pathogenesis of autoimmune pancreatitis. It seems to be a complex interplay of humoral as well as cell-mediated immunity, the details of which still have to be unraveled. And importantly, if you see at the pathology of this disease, there is intense inflammation, but the disease does not have any pain. We really don't know what are the reasons for that, in contrast to other types of chronic pancreatitis, where pain is an important hallmark of the disease. And hence, the pathogenesis is still incompletely understood, and that's why we are still learning. If you look at epidemiology, majority of the studies are either from the US or from Japan and other Eastern Asian countries. And the studies have shown that it comprises about 2% of chronic pancreatitis. And in pancreatic resections for a presumed malignancy, 2.5% of them have been approximately described to be having autoimmune pancreatitis. And these numbers have been gradually increasing because of increased awareness. Now, if you look at India, this was a paper published in Tropical Gastroenterology, 2000 to 2006, out of 524 cases of chronic pancreatitis, there was not even a single case of autoimmune pancreatitis. And in the study period from 2007 to 2013, the number increased to 0.5%. Then we looked at our data of resections, and in resections, we found that autoimmune pancreatitis was present in 3.5% of pancreatic resections done for presumed malignancy. And then looking at the clinical data of last 8 years of all the patients of chronic pancreatitis seen at our center, the prevalence of autoimmune pancreatitis was 2.6%. So approximately, possibly because of now increased awareness, the epidemiology of autoimmune pancreatitis probably is similar across the world. It was just that initially there was not much awareness and we were not accurately diagnosing this disease. Now, before we go on to the clinical features, let's look at the types of autoimmune pancreatitis. Now, the autoimmune pancreatitis has been divided into two types, type 1 and type 2. For a clinician, it is very important to remember that it is difficult to accurately distinguish these two types based on only clinical and imaging features. The confident diagnosis of type 1 and type 2 requires histopathological analysis. The type 1 autoimmune pancreatitis is a part of group of diseases which is now called as IgG4 related diseases. It is also known as lymphoplasmacytic sclerosing pancreatitis based upon the histopathological hallmark of this disease. It is also known as IgG4 related autoimmune pancreatitis. In this, classically, the patients have high serum levels of IgG4, which is usually more than 140 milligram per deciliter. And these patients have a considerable risk of recurrence after steroid therapy. They respond very well, but almost 40% of these patients will relapse. In contrast, the type 2 autoimmune pancreatitis is not associated with IgG4 related disease. It's a disease which is predominantly localized to pancreas only. It is known as idiopathic duct-centric pancreatitis. The classical histopathological hallmark of this disease we all know is a granulocytic epithelial lesion, or GEL, which is known as commonly. And in this subgroup of patients, pancreatitis is a common symptom and ulcerative colitis is commonly associated. The serum IgG4 is usually normal, and the recurrence rates after steroid therapy are practically unknown. It's very, very low after response to steroids. Now, after understanding these two types of AIP, let's look at the clinical manifestations. This disease, as I've already told you, is common in elderly males, but then we have to remember that it's also seen in females as well as in children. So classically in elderly males, but it can be seen in other subgroups also. It has a varied clinical presentation, but we have to remember that most of these patients present subacutely, and acute presentation is almost unknown of autoimmune pancreatitis. And in some patients, it may be incidentally detected through the radiological findings, which we are going to hear from Dr. Madhusudan, or unexpectedly in pathological specimens for dissections done for presumed malignancy. Most symptomatic patients of acute autoimmune pancreatitis will present with either obstructive jaundice or will present with a pancreatic mass that often mimics a pancreatic adenocarcinoma. Less often, these patients may present with acute pancreatitis or an abdominal pain. This is usually seen in type 2 AIP, but again, these patients will have biochemical features of obstructive jaundice in the form of elevated alkaline phosphatase or mild elevation of bilirubin, and these patients usually have mild and intermittent pain. presence of severe narcotic requiring or a chronic pain unlikely to be an AIP, and similarly presence of anorexia and significant unexplained weight loss is not seen in autoimmune pancreatitis. Then what about other extra pancreatic manifestations which can be seen in these patients? Most commonly associated disease is IBD, mostly ulcerative colitis in type 2 AIP. Otherwise, you can have a wide spectrum of IgG4 related extra pancreatic manifestations, including cholangitis, lung nodules, adenopathy, infiltrates in the lung, Sjogren's syndrome, retroperitoneal fibrosis, bile duct strictures, and these strictures characteristically are long strictures without bleeding. You can have a tubulointerstitial nephritis, which can be symptomatic or asymptomatic, and finally autoimmune thyroiditis, which all are a part of a spectrum of IgG4 related disease. Now let's go to the lab markers. Serum IgG4 is one of the most commonly used tests for diagnosis of AIP. IgG4 in a normal person comprises about 5 to 6% of total IgG and is less than 140 milligram per deciliter. Studies have shown that if IgG4 is more than or equal to 2 times the upper limit of normal, it is highly suggestive of autoimmune pancreatitis. And meta-analysis has yielded a sensitivity and specificity of about ranging from 67 to 94% and 89 to 100% respectively. Type 1 autoimmune pancreatitis almost always is associated with elevated serum IgG4. However, type 2 autoimmune pancreatitis most commonly does not have an elevated serum IgG4. And we also have to remember that IgG4 elevation is also seen in pancreatic cancer, atopic dermatitis, asthma, a lot of parasitic diseases, pemphigus vulgaris, and pemphigus foliaceus. But in most of these diseases, the elevation is less than 2 times the upper limit of normal. What about other antibodies? There are a lot of other autoantibodies that have been studied. The most promising have been anti-plasminogen binding protein peptides for diagnosis of autoimmune pancreatitis. Other autoantibodies are carbonic anhydrase antigens, lactoferrin, secretory trypsin inhibitors, but none of these biomarkers are better than IgG4, and even IgG4 is not very sensitive and specific enough for confident diagnosis of autoimmune pancreatitis. What about role of CA19-9? Because we know that pancreatic malignancy is a common differential for autoimmune pancreatitis. Can it help in diagnosing? Studies have shown that 47 to 73% of patients with AIP will have a CA19-9 elevation. Hence, it does not have any role in differentiating pancreatic cancer from autoimmune pancreatitis. Now, how do we diagnose autoimmune pancreatitis, since we have understood that there is no single investigation which can help in a confident diagnosis of autoimmune pancreatitis? So what we have to do is, there are a lot of diagnostic criteria which have been proposed. I won't go into the details of those diagnostic criteria. And the studies have shown that none of these diagnostic criteria is 100% sensitive. So many of these diagnostic criteria are going to miss autoimmune pancreatitis, and still sometimes we may be misdiagnosing pancreatic cancer as an autoimmune pancreatitis. So hence one has to do a stepwise careful diagnosis. So let's look at type 1 AIP first. How do we diagnose? Is biopsy mandatory? What in type 1 AIP, what we have to do is one has to do a close examination of imaging of the pancreatic parenchyma with either CT or MR, which Dr. Madhusudan is going to discuss. What we have to remember is that patients with the normal cross-sectional imaging, the diagnosis of AIP is unlikely. Once we have done that, we look at serum IgG4 and carefully look for other organ involvement. And finally, if we don't have a convincing evidence, we go on to FNA or biopsy. So first is on a imaging, if you have typical features, the typical features are going to be discussed subsequently. That if that thing is present, you just need any non-ductal imaging collateral evidence. That is, either you have to have an elevated IgG4 or presence of other organ involvement, which again, Dr. Madhusudan is going to discuss. So if these two things are present, you can have a confident diagnosis of type 1 AIP. The differentials in this situations are acute interstitial pancreatitis and pancreatic lymphoma. But again, imaging is characteristic for these two diseases. So enhancement pattern, other things can help in differentials. And in this situation, an FDG PET might help in identification of other organ involvement. On the other hand, if you have a focal involvement of pancreas in the form of a low density mass, or you have atypical features like the enhancement is not characteristic, the duct is dilated, or there is distal atrophy, in this situation, you need two strong collateral evidence out of these three. So one is a PD stricture without upstream dilatation, serum IgG4 more than 2 times the upper limit of normal, and histological demonstration of other organ involvement or you have a radiographic presence of a proximal biliary disease or retroperitoneal fibrosis. So if two of these three criteria are present, along with the imaging features, again, you can diagnose confidently AIP. However, if you have only one criteria, that means out of these three criteria, one criteria is present, we call it as a modest collateral evidence. In this situation, regardless of the imaging features, you have to do an FNA to confirm. And if FNA is not confirmatory, one may have to do a core biopsy. Now, what about type 2 AIP? Type 2 AIP is a much difficult game of diagnosis because the IgG4 is negative. There is no other organ involvement. Hence, a confident diagnosis of type 2 AIP requires histology. But then we can classify this disease as probable type 2 AIP if you have concomitant IBD with features on imaging and response to steroids. So what we do is a stepwise evaluation, look at elevation of IgG4 or multi-organ involvement. If that is not there, then type 1 AIP is not there. You have to work up for type 2 AIP. Then you have to do a negative workup for cancer, and contemporary diagnosis of IBD and showing a response to steroids makes it a probable case of type 2 AIP. What about role of biopsy and then which needle? We know that diagnosis of AIP requires the presence of three of the following findings, which is lymphoplasmacytic infiltrate, storiform fibrosis, obliterated phlebitis, and more than 10 raised to power, more than 10 Ig4 positive cells per high far field. In FNA, we can only assess one of this, that is presence of IgG4. Hence, ICDC, that's the diagnostic criteria, has recommended a core biopsy or surgical biopsy for diagnosis, and EUS guided FNB is now the practice of choice for obtaining the core. What about ampullary biopsy? Ampullary biopsy, there was a lot of studies on ampullary biopsy, but it relies solely on elevated number of IgG4 positive plasma cells, and hence it is not used for a diagnosis of AIP. And more importantly, we know that type 2 AIP, there are no plasma cells, hence it cannot help. What about the role of steroid trial and diagnosis? A word of caution about steroid trial, although there's a lot of literature of using steroids and looking at response at 2 or 4 weeks. But in focal forms of autoimmune pancreatitis, suspected AIP, it should be used with caution, especially at experienced centers, because the risk to treat cancer with steroid is phenomenal. And many times, if you have a resectable pancreatic mass, 90% of the time the diagnosis is going to be adenocarcinoma. So I advocate a steroid trial only in diffuse form of disease where one may have a chance that you are not going to miss a malignancy. But despite all this, you still may be doing a resection for autoimmune pancreatitis. So missing a pancreatic cancer is probably more disastrous than doing a resection for autoimmune pancreatitis. Just to end my talk, I'll just show you one case to just illustrate the same point, that how difficult it is to make a confident diagnosis of autoimmune pancreatitis. This is a young boy, 21-year-old, with a presentation of abdominal pain, no jaundice, no elevation of alkaline phosphatase, CT head showing a hypotense mass in the uncinate head of pancreas, CA19-9 little bit elevated, IgG4 quite high. FDG PET done outside showed an avid lesion in the uncinate process of pancreas. On EUS, there is a ill-defined hypoechoic mass lesion in the head of pancreas, no vascular invasion, elastography showing it to be a stiff lesion. A core biopsy done, tissue core is not obtained, the specimen obtained is spread on a slide. It shows these well-defined monomorphic cells suggesting a possibility of a neuroendocrine tumor. So this was reviewed by cytopathologist. Again, because of this morphology and large nucleus, little bit variation in size, they felt it's a neuroendocrine tumor. Patient underwent a DOTA PET. Again, the same lesion was showing an uptake of DOTA. There was no uptake anywhere else, either on FDG or DOTA. So patient undergoes a resection, and on resection of these features, this is extensive fibrosis, lymphoplasmacytic infiltrate, IgG4 positive plasma cells. And from where did we get the neuroendocrine cells? Because of the extensive loss of SNI and fibrosis, there was crowding of these islets, and probably the needle would have sampled these islets, which are looking like a hypertrophied islets in the uncinate process. That's why we got a diagnosis of a neuroendocrine tumor on cytology. Thank you so much for listening patiently to this talk. Now I'll hand it over to Dr. Madhusudan to talk about radiology in autoimmune pancreatitis before I come back for the management of AIP.
Thank you, Dr. Surinder. And at the outset, I'd like to thank the Indian Pancreas Club for inviting me to this webinar. Let me start sharing my slides. Yeah, so let me talk about the radiological diagnosis of autoimmune pancreatitis. As Dr. Surender has very nicely shown that it's a part of variant of chronic pancreatitis, and it may form variably from 1.8 to 11% of all chronic pancreatitis. And initially it was known that it is mainly IgG4 related disease. Now we know that the type 1 is the one which is an IgG related part of the IgG related disease and not the type 2 one. And then typically it has this IgG4 positive plasma cells. And when it occurs focally, it may mimic pancreatic malignancy, and from which differentiation on imaging may not be possible most of the times. So this has also been discussed, and again you can see that this is the table form differentiation of type 1 and type 2 autoimmune pancreatitis, and again you can see that the differentiating features, there is no imaging included, so suggesting that the imaging patterns of type 1 and type 2 are more or less the same, and they have similar imaging features, and based on imaging it is not possible usually to differentiate type 1 and type 2 autoimmune pancreatitis. So let's see what is the role of imaging. So the main important role is in defining the morphology and extent of the disease. So once you define the morphology and extent, it may help in suggesting a diagnosis of autoimmune pancreatitis. And then another important role of imaging is to assess the involvement of other organs, as association extra pancreatic involvement is commonly seen in patients with autoimmune pancreatitis, particularly type 1 autoimmune pancreatitis. And then the third important role is assessing treatment response. Once treatment with steroids or other immunomodulators has been started, then imaging will help in assessing the response to the treatment. These are the various modalities which are available. And as I said, type 1 and type 2 have similar imaging features. But whenever you see atypical findings like focal involvement of the pancreas or atrophy of the pancreas, it is said that they are more commonly seen in type 2 autoimmune pancreatitis rather than in type 1 autoimmune pancreatitis. So these are some of the imaging features. So ultrasound being the first imaging modality in all patients presenting with abdominal pain or jaundice, which are the common manifestations in acute autoimmune pancreatitis. There may be a bulky hypoechoic pancreas, diffusely hypoechoic pancreas. You can see the lobulated outline of the pancreas may be lost, and sometimes you may see this hypoechoic band around the pancreas, so which is a capsule which is seen often in patients with autoimmune pancreatitis. Or you may have the lobulated outline when sometimes you may have multifocal involvement of the pancreas. Another important finding which you can see on ultrasound is the biliary involvement. So this is the most common extrapancreatic involvement in patients with autoimmune pancreatitis. And you can see that there is thickening, wall thickening of the bile duct. This is the bile duct which is wall thickening. This is in the axial section. You can see that the very well-defined wall thickening, and despite the presence of wall thickening, lumen is clearly seen. So this is one of the characteristic feature of autoimmune IgG4 related sclerosing cholangitis. In fact, when it involves the biliary tree. Then CT scan is probably one of the common imaging modalities which is done in a patient with abdominal pain. So this typically shows diffusely bulky pancreas, typically sausage-shaped pancreas, and then you have this capsule. It's a band of hypodense soft tissue which is seen encapsulating the entire pancreas. So this is a very characteristic feature of autoimmune pancreatitis. And in addition, if there is extra pancreatic manifestation like this is the CBD which is showing gross thickening, and then lumen is still seen in this. So these are the coronal pictures. This is the pancreas which is very bulky, and this hypoechoic hypodense band what you see is the capsule encircling the pancreas. And then this is the CBD showing a band like wall thickening. Then MR is probably more commonly done because this gives better imaging appearance than CT scan. And there are a few specific features for autoimmune pancreatitis here. And as I suggested, the pancreas is bulky and sausage shaped. So as you can see, these are the T2 weighted images and then the T1 weighted images. And then typically on a T2 weighted image, you can see this hypointense band. Okay, so this suggests that there is fibrous band encircling the pancreas entirely. Then another important feature is the restriction on diffusion weighted images. This is the diffusion weighted image, and this is the ADC maps which suggests source which is hypointense. The entire pancreas is hypointense on this, suggesting that there is diffuse restriction of diffusion. And then on serial contrast, dynamic contrast enhanced imaging, you can see that the pancreas as well as the capsule, what you see shows progressive enhancement. So this is the pancreas, here, and then the hypointense capsule which is seen. We can see that as there is a delay in the imaging, you can see that there is more and more enhancement of the pancreas as well as of the fibrous band. So this suggests that there is fibrosis deposited within the pancreas as well as in the pancreatic the capsule encircling the pancreas. Then MRCP has again few specific features. Despite the diffuse involvement, there is hardly much dilatation of the pancreas. You may see long segment strictures of the pancreas, and then despite, again, as I mentioned, despite the presence of these strictures, the dilatation is very mild, usually less than 5 mm, and then there may be multifocal strictures as well. And then MRCP will also help you in identification of involvement of the biliary tree. As you can see in this case, there is more sclerosing cholangitis like picture involving the intrahepatic as well as the extrahepatic part of the bile duct. Then there are few atypical features which are seen, and literature suggests that 30 to 40% of the cases of AAP may have focal presentation. So these are two such cases which we had encountered. So this is one patient, middle-aged lady, who had a mass in the pancreatic tail, and it was shown, it was imaging wise, we had suggested a malignancy, but then we had to do a biopsy, and then biopsy showed that it was IgG4 related disease, focal pancreatitis. And then this was a child which had who presented with jaundice, and there was a big mass in the head of the pancreas. And then this again on biopsy was shown as autoimmune pancreatitis. So few features. One important feature is the duct penetrating sign. If you can see the duct through the mass, especially when the mass is in the head of the pancreas, and then if you can see either the CBD or the pancreatic duct going through the mass, you can see here. So these two are the ducts. If you can see them through going through the mass, you can suggest that it is likely to be inflammatory and less likely to be malignant. And an uncommon presentation is atrophic pancreas. It is known that autoimmune pancreatitis may spontaneously resolve without treatment, and this is one such case where there is a burnt out disease. In this patient, IgG4 levels were elevated. Another important role is to identify the other organ involvement. As I mentioned, 80 to 90% of these patients with autoimmune pancreatitis, typically type 1, will have a biliary involvement. The most common site of involvement is the distal part of the common bile duct, because this is the part where it is intrapancreatic in segment, and because of the involvement of the pancreas, there is involvement of the distal CBD as well. And then you can have PC kind of a picture where there is involvement of intrahepatic as well as the extrahepatic bile duct, in addition to the pancreatic duct involvement. Then the other organs which are involved are the kidneys. You can see hypointense focal lesions within the cortex of the kidneys, and you can have multiple focal lesions on both kidneys. Then the other finding, extra pancreatic feature, is the retroperitoneal fibrosis. This is the aorta. You can see this fibrous soft tissue surrounding the aorta, and then this is the contrast enhancement. You can see the soft tissue which is seen all around the celiac axis and the aorta itself. Then you can have involvement of the salivary glands and then lacrimal glands. So these are all the extra pancreatic manifestations in autoimmune pancreatitis which can be identified on imaging. Then US has already been stressed on. It has a role in obtaining biopsies, and you can see US can help in obtaining biopsies from the head of the pancreas or body of the pancreas, and this is important in often in cases where imaging is not very definitive or very suggestive of IgG4 related disease. So this is the HISORT criteria which is usually followed in making a diagnosis of autoimmune pancreatitis. And you can see here histology is very important in making a diagnosis. And in addition to histology, you should have one of the other features. So histology plus imaging is helpful in making a diagnosis. And in the absence of histology, you can see that the criterion of imaging plus serology, if you have elevated IgG4 levels, can be suggestive of a diagnosis of autoimmune pancreatitis. And in the absence of all these, because sometimes IgG4 may be normal and histology may not be available, then presence of imaging features and then other organ involvement. So these two features itself may be may help in giving a probable diagnosis of autoimmune pancreatitis. Differential diagnosis, lymphoma. So in the presence of the lymphoma can diffusely involve the pancreas, but it's usually associated with the lymph nodes in the surrounding area. It has diffuse involvement of the pancreas, and then it shows homogeneous contrast enhancement, and there is hardly any fibrosis. So there are some features which may help in making a differentiation, especially presence of lymph nodes. Acute pancreatitis, usually you see collections surrounding the pancreas. There are inflammatory signs in the peripancreatic location, and the presentation is usually acute, which is very uncommon in autoimmune pancreatitis. And then pancreatic carcinoma, this is especially important because whenever there is a focal kind of autoimmune pancreatitis, this becomes an important differentiating feature. Duct cutoff sign, pancreatic atrophy are the features which are commonly seen in pancreatic carcinoma. And again, we hardly see extra pancreatic manifestations in patients with pancreatic carcinoma. Treatment, this will be discussed by Dr. Surinder, but imaging is important because you can see that this is a patient with autoimmune pancreatitis, and on follow-up there is atrophy. So this is one of the important feature, and imaging is helpful in assessing the response to treatment as well. So in conclusion, AP is a rare kind of chronic pancreatitis, and type 1 is the one which is a pancreatic manifestation of IgG4 related disease. Imaging is helpful, particularly MR is helpful in suggesting a diagnosis, defining the extent of the disease, and also in follow-up. And most of the time, diagnosis requires a Hazard criteria. Thank you for your kind attention.
Thank you, Dr. Madhusudan, for an excellent overview on imaging in autoimmune pancreatitis. So I return back to my presentation. We talk about the management of autoimmune pancreatitis. So I'll briefly talk about the management. So are the slides visible now?
Yeah. Yes, we can see. Yes.
Okay. So when we start thinking about managing a patient of autoimmune pancreatitis, the questions which we need to answer is which patient should be treated. In patients who present with obstructive jaundice, do we need biliary drainage before treatment? Because these patients are to be given steroids. What is the best induction regime for steroid treatment? When to taper and when to stop the initial steroid treatment? Who are the patients who needs maintenance treatment, and how to treat the relapsing patients? At the outset, I would acknowledge that there are no randomized studies to study the effect of treatment, so we don't know which is the best regime. Most of these studies are based on retrospective analysis. There have been various treatment regimes advocated, but most of them use steroids. So there is no doubt that the symptomatic patient needs to be treated. And what about asymptomatic patients? Asymptomatic patients are to be kept under observation, except the patients who have to have a persistent pancreatic mass on imaging, because the ongoing inflammation can lead on to pancreatic exocrine as well as endocrine insufficiency if not treated. And similarly, patients who have other organ involvement with persistent liver test abnormalities suggesting asymptomatic biliary tract involvement. So these patients are at risk for secondary biliary cirrhosis. Patients who have lacrimal glands involvement, because this can lead on to dryness of eyes. And finally, patients who have asymptomatic retroperitoneal fibrosis also needs to be treated because of long-term consequences of untreated retroperitoneal fibrosis. The induction steroids are the treatment of choice. They are the first-line agents for treatment of active untreated autoimmune pancreatitis. There are two regimes which have been advocated, either a weight-based, that is 0.6 to 1 milligram per kg per day, or a fixed high dose, which is 40 milligram per day. There are a few studies which have shown that even a lesser dose, up to 20 milligram per day, is also associated with good induction. But important point to remember that doses less than 20 milligram per day should not be used for induction because they are not effective. The patient should be evaluated 2 to 4 weeks later, as Dr. Madhusudan has talked about, with the same imaging modality before starting therapy, particularly in the focal form of disease, to demonstrate the significant response with steroids. And once that has been demonstrated, the steroids are to be tapered by 5 to 10 milligram per week after the 4-week period. And this duration of remission treatment, that means the tapering should gradually go on for a minimum of 3 months, because this is known to decrease the risk of relapse, especially in type 1 autoimmune pancreatitis. Some of the authors have advocated, especially from Japan, to use a maintenance dose of 2.5 to 5 milligram per day of prednisolone for up to 2 years, because they have shown that this maintenance therapy decreases the risk of relapse. What about alternatives? You are going to have patients who are either intolerant or there are contraindications to use of steroids. Azathioprine is not indicated for induction because we all know that the therapeutic efficacy for azathioprine is reached in 2 to 3 months. So in this class of patients who are either non-responders or have contraindications to steroids, rituximab has been shown to be an excellent alternative. And patients who have proximal biliary involvement, who have a disease onset at a younger age, and who have a higher alkaline phosphatase levels, more than 4 times the upper limit of normal, can be given rituximab, because these patients have been shown to have a better response to rituximab, less chances of steroid-related side effects, and lower risk of relapse. What's the dose of rituximab? It is usually given in one of the two ways. One is to give 1,000 milligram on day 1 and day 15. That's how it is done in rheumatoid arthritis. Or 375 milligram per meter square. That comes to about 500 milligram in most adult patients once weekly for 4 weeks. So cumulative dose comes on to be same. So this is the induction regime for rituximab. Then the second question, is biliary drainage needed? Because many of the patients, especially with the focal mass, have jaundice. And biliary drainage is useful to prevent biliary infection because you are going to give steroids. And brushing and cytology can also help in ruling out a biliary malignancy. But then it's a double-edged sword where studies have shown that doing a biliary drainage and then giving steroids also increases the risk of cholangitis. The consensus right now is that patients with mild jaundice without cholangitis, steroid treatment alone can be given safely without biliary stenting. But patients who have a bilirubin more than 6 milligram per deciliter should be drained along with the steroid therapy. What about steroid refractory cases? I have already talked about rituximab. The other option is to give a steroid mini pulse treatment. There is only one study with about 12 patients where 2 courses of methyl prednisolone of 500 milligram, 3 days with 4 days interval was given. And this has shown to be an excellent treatment regime for patients who are refractory to conventional steroid therapy. What about maintenance treatment? Now, patients who have a type 1 autoimmune pancreatitis with low disease activity, that means the IgG4 levels are not very high, the IgG4 levels come immediately down after therapy, or patients who have type 2 AIP, there is no role of maintenance therapy. However, patients who have type 1 autoimmune pancreatitis and have serum IgG4 levels which are more than 4 times the upper limit of normal, and then patients who have a persistently higher serum IgG4 levels despite steroid treatment and clinical improvement, the patients who have a diffuse enlargement of pancreas, that means the diffuse type of disease, patients who have a coexistent proximal type of IgG4 sclerosing cholangitis, that means hilar strictures, and if there is extensive, that means more than or equal to 2 other organ involvement with IgG4 related diseases, these are the patients who need to be given a maintenance therapy. And maintenance therapy can be given either in the form of low dose steroids, which I've already talked, or steroid sparing agents like azathioprine at 2 milligram per kg per day, 6 mercaptopurine at 1 milligram per kg per day, or mycophenolate mofetil 750 to 1000 milligram twice daily have been used as options for maintenance therapy in autoimmune pancreatitis. Finally, what's the role of surgery? We being medical gastroenterologists should not forget surgery in autoimmune pancreatitis. It may be useful in refractory cases, and throughout our experience of resections in autoimmune pancreatitis, we know that the patients who underwent a palliative resection or a bypass achieve successful clinical remission, and these patients rarely relapse post-surgery. So in refractory cases, surgery also may be considered. So let's, in a brief flowchart, look how do we treat autoimmune pancreatitis. Once you have a diagnosed case of autoimmune pancreatitis based upon the diagnostic criteria I just elaborated, we look at the symptoms. If the patient is clinically symptomatic in the form of pain or jaundice, or if there is other organ involvement in the form of salivary glands, retroperitoneal fibrosis, or biliary involvement, these patients need to be treated. If these things are not present, then these patients are to be kept under observation. Before starting treatment, if the patient is diabetic, control the blood sugars. And if bilirubin is more than 6, do a biliary drainage. And then assess for steroid intolerance or adverse effects. Like, for example, if you have patients who are young, they will be on steroids for a longer time. So in these patients, alternatives may be considered. If there is no risk for steroid adverse effect or intolerance, then steroids can be given at the dose which I've already talked about. And the patients will go into remission, because we know that this disease responds very well to steroids. And if they have a risk for steroid intolerance, then the option is to use rituximab. The other alternatives which have been used in case reports are mycophenolate and tacrolimus, but I think rituximab is probably the best bet. And once the patient goes into remission, we again reassess the patient at 4 weeks. If there is a rapid radiological response, normalize IgG4 after treatment, and there is no other organ involvement before treatment, there is no need for maintenance therapy, and these patients can be kept on observation. And if there is a diffusely enlarged pancreas, that is a diffuse disease, delayed radiological remission, that means at 4 weeks still some radiological telltale signs of disease are present. If the IgG4 are still elevated after treatment, or if 2 or more, that is extensive other organ involvement is present before therapy, these patients should be maintained on maintenance therapy, because these are the subgroup of patients who are at high risk of relapse. Type 2 autoimmune pancreatitis does not relapse, and there is no need for maintenance therapy. So to conclude, we have learned that autoimmune pancreatitis is comprised of two distinct forms of steroid responsive chronic pancreatitis. One is lymphoplasmacytic sclerosing pancreatitis, LPSP, or type 1 AIP, and idiopathic duct-centric pancreatitis, or type 2 AIP. LPSP is a relapsing remitting disease and often requires use of maintenance immunomodulation. The factors which one has to assess for maintenance therapy I have already elucidated. In contrast, the duct-centric chronic pancreatitis does not relapse after initial treatment, so it's very good steroid responsive both on short and long term. Circumstantial evidence currently suggests that autoimmune pancreatitis is an autoimmune process, but we still don't have the detailed pathogenesis unraveled. The treatment strategy which I have talked is effective, but it needs to be validated by prospective comparative studies to find out which is the best regime. Although the disease is steroid responsive, but maintaining remission, especially in type 1 autoimmune pancreatitis, continues to remain challenging. Thank you so much.
Thank you, Dr. Rana, for excellent presentation on diagnosis, epidemiology, and management of patients with autoimmune pancreatitis. I'll start the ball rolling by asking you the very basic question. Both type 1 and type 2 are totally distinct entities. They have nothing in common. One, if you look at the epidemiology, the prevalence, the incidence, the pathogenesis, totally different. Why are they still clubbed together? But what is common between the two? Could they be, 90% of the patient of autoimmune pancreatitis are type 1, which is a totally different, it is basically should be called IgG4 disease. In fact, true autoimmune pancreatitis should be only duct-centric pancreatitis. That means there is a destruction of the duct. Pathologically, they are different. There is no IgG4, treatment is different. Why are they still clubbed together?
Yeah, I agree with you perfectly, because, I think they are clubbed together for two reasons. First is presumed autoimmune pathogenesis of the disease for both the disease entities. And second is the response to steroids, because we believe that autoimmune diseases are going to respond very well to steroids. But if you look at recent classifications, the type 1 is more commonly called as an IgG4 related pancreatitis, and type 2 is known as an autoimmune pancreatitis. But, historically, the type 1 started as an autoimmune pancreatitis. So, both of them are clubbed together, and, various classifications are there. But I think for a gastroenterologist, it's much easier to remember as type 1 and type 2, and broadly knowing that type 1 is an IgG4 related disease and type 2 is a distinct form of autoimmune pancreatitis. The basic denominator or commonality between them being response to steroids.
Yeah, but that is too small a thing. If you look at the basic pathogenesis, where does the trigger lie, say in type 1 and type 2?
Yeah, that's the question which needs to answer. We really don't know what is the antigen which is triggering this autoimmune pancreatitis. What is the target for IgG4? We really don't know, despite studying this disease for so long. I think probably the rarity of the disease and, getting histological specimens for genetic analysis or autoimmune analysis, all these are limitations. So I think probably in next few years, we will be much wiser about the pathogenesis of this disease.
Maybe we are just trying to understand the disease in total. We are totally dive into the pathogenesis of the disease. And we have a set of questions from the audience. The first question is addressed to Dr. Madhusudan. Dr. Madhu, why is it, this is a question from Dr. Anant Gupta, why is there a upstream dilatation of the pancreatic duct coupled with atrophy of the pancreas in carcinoma pancreas versus with a similar pathology in patient with autoimmune pancreatitis in which the duct doesn't get dilated? What is the radiological explanation?
So it mainly, the reason is the location of the disease. In CA pancreas, it's mainly the epithelium from where it's the ductal adenocarcinoma. It arises from the ductal epithelium, so it directly flows into the lumen and causes the obstruction of the duct. Compared to an IgG4 disease or autoimmune pancreatitis, it's a mainly subepithelial disease. So the epithelium is although infiltrated, but it doesn't grow into the lumen. It's mainly subepithelial and extraluminal disease. So that is the main reason why there is duct obstruction in patients with CA pancreas compared to IgG4 related disease.
Could there be another explanation? I'm just, just conjecturing that, in our type 2 autoimmune pancreatitis, the basic definition is gel, that is granulocytic epithelial lesion. That means by default, it starts in epithelium. Basic difference between the two is since most of the pancreas are in the head of the pancreas, so the distriction and the local injury is only in the head of the pancreas. So you get rest of the nascent pancreas, you let it dilate. Whereas by default, autoimmune pancreatitis is duct centric. It involves the whole of the duct and possibly doesn't give time for dilatation. That could be another.
I think one of the important reasons for that is that the difference between the two is the epithelium is never destroyed in autoimmune pancreatitis. The pancreatic duct epithelium is always intact, and the inflammation and fibrosis is predominantly subepithelial. So it's involving the duct throughout, and it is causing subepithelial fibrosis leading on to narrowing, and plus it never causes luminal obstruction. So once your epithelium is intact, you're not going to have a luminal obstruction. So that's why you have non-dilated duct with narrowing.
Second question again addressed to Dr. Madhusudan is again from Dr. Anant Gupta. How do we differentiate in the CBD involvement in autoimmune pancreatitis versus IgG4 sclerosing cholangitis? Are they different entities at all?
No, they're not. So IgG4 sclerosing cholangitis is the term which we use when there is predominant involvement of the biliary tree and there is no pancreatic involvement. So that is the situation when we use the term IgG4 sclerosing cholangitis. But in presence of autoimmune pancreatitis, it is still the part of the same disease, whether it is involving the lower part or.
Since there is an overlap of so many, other organ involvement and IgG4 infiltration, because the levels are raised in the blood, so they can infiltrate any tissues. So if there is a predominant involvement of the CBD, you will call it autoimmune IgG4 related cholangiopathy. If there is a concomitant involvement of pancreatitis, you will have it both. Third question is, this is addressed to Dr. Surendra Rana. What is the incidence of autoimmune pancreatitis presenting as recurrent acute pancreatitis? To my knowledge, recurrent acute pancreatitis, you should not think of, it practically never happens in patients with autoimmune.
It's a good question, sir. I think the incidence of AIP presenting as RAP depends upon the competence of your radiologist. Yeah. Because if you have patient presenting with an acute pancreatitis, and the radiologist will invariably, give a suspected diagnosis of AIP if properly a CT has been done. So we know that from various centers which have looked at AIP, almost 30% patients will present as acute pancreatitis. And most of the radiologists are now well trained, and they will probably give you a suspected diagnosis of AIP when you find an interstitial pancreatitis, no necrosis. So I think RAP is probably very, very rare. If you are missing it the first time, then you may have an RAP.
So if you have a good radiologist like Dr. Madhusudan, you don't diagnose recurrent acute pancreatitis because of autoimmune etiology. Is that what you mean?
Yeah, that's right.
Everybody is not lucky to have people like Madhusudan.
Can I also make a point?
Yes, sir.
Yeah.
So type 1 AIP, it does not present with acute abdominal pain. So I think type 1 AIP should not be confused with RAP. Many people order nowadays IgG4, and at times you find IgG4 is raised and these patients are treated with steroids. We have seen many patients. And moreover, type 1 AIP is a disease of elderly. We do see sometimes in younger people, but it's a disease of elderly. While RAP is typically seen in younger patients. Type 2 AIPs is sometimes present with acute pancreatitis. And that is something that is even rarer in India and even rare outside also. So I think what Dr. Arora is saying is I think absolutely correct, that one should not confuse autoimmune pancreatitis as a cause of RAP.
Especially recurrent pancreatitis.
Yes, RAP means recurrent acute. Yeah, that's right.
Next question is addressed again to Dr. Madhusudan. So when there is a focal mass in the pancreas, be it in the head or the body, this is from Dr. Venkateshwan, can a PET distinguish between a focal autoimmune pancreatitis versus adenocarcinoma?
Sir, PET only shows uptake in the tissue. So whether it is because AAP is also an inflammatory disease and PET is used to diagnose even extra pancreatic involvement as well. So PET has a role in IgG4 related disease. So wherever there is inflammation, uptake is seen on PET. And then even in adenocarcinoma, you see an uptake. So based on PET imaging, it is very difficult to differentiate a focal autoimmune pancreatitis and an adenocarcinoma.
I think this is an ideal situation where EUS and an directed FNA will come handy. Next question is, any role of combination of low dose steroid with immunomodulator for long-term maintenance therapy? Dr. Rana, any combination of azathioprine and steroids to begin with, especially if the person is diabetic?
I think there is no study, to the best of my knowledge, which has looked at the combination therapy for AIP. I think this question probably arises from the fact that we use a combination therapy in autoimmune hepatitis. But here the disease is so well responsive to steroids, you can give steroids for 4 weeks and then put the patient on maintenance. So there is no need to give a combined therapy. And if patients are not responsive to steroids, you have rituximab, which is a fairly good therapeutic option.
Okay, and another naive question again. You see, in the diagnostic ICDC criteria, the level of IgG4 which is mentioned is 134. Whereas when you talk of diagnostic definitive criteria, you always talk of level more than 2. So which one should be important? Because the sensitivity will vary drastically if you take more than 2 times the upper limit of normal versus more than 135.
So I think the higher the threshold you set, you will have higher specificity. So it's always a balance between sensitivity and specificity. So whatever is the normal value of your labs, more than 2 times the upper limit of normal, I would believe probably is a better diagnostic criteria. But again, we know that IgG4 is not a panacea for diagnosis. It's one of the supportive evidence.
But the standard definition says more than 1.4 gram per liter is the standard, because the upper limit of normal is variable, also depends on the type of test that you do from lab to lab. So in general, more than 1.4 gram per liter is the one which is considered a reasonable limit.
So 2 times is not needed because the sensitivity will drop down drastically if you take it more than
2 times would be in fact lower than 1.4. It depends on your upper limit of normal.
Okay. And Dr. Madhu, can a PET differentiate between active disease and fibrosis?
Yes, especially in IgG4 related disease, PET has been used in follow-up of patients because a whole body scan on MR or CT scan may not be easily possible. And in those situations, we usually do a PET CT scan to see the uptake and then to see the response to treatment. So similarly for pancreas as well, it will help in differentiating whether the disease is still active or the pancreas has undergone complete fibrosis and has responded to the treatment. It is useful.
Then next question is both maybe Dr. Rana and Dr. Pankaj. The literature is riddled with controversies regarding the association of autoimmune pancreatitis and malignancy. Is it a pre-malignant condition?
You have, I think, already highlighted that, so there is very scarce literature on this aspect. But there have been few reports of patients of autoimmune pancreatitis who have been on follow-up developing pancreatic cancer. So I won't currently call it a pre-malignant disease, but then there is increased risk of cancer and these patients needs to be on surveillance for detection of cancer. But it is not something which is quite common as it is seen in hereditary pancreatitis or other forms of chronic pancreatitis.
Because if you look at the literature, different studies quote that in patient with autoimmune pancreatitis, you are more likely to have extra pancreatic malignancy, lung, gallbladder, etc. Because you are more likely to have a KRAS mutation in the biliary tract and gallbladder. Whereas other studies show that CA head of the pancreas is more likely. Dr. Pankaj, Pramod, you like to answer?
No, just wanted to say that it is not, and we should not recommend surveillance for pancreatic cancer. In fact, even in hereditary pancreatitis, there are questions about surveillance. So surveillance itself has huge implications, and certainly for autoimmune, I don't think we need to have surveillance. The important point which Dr. Rana has highlighted is the confusion in the beginning. Is it cancer or it is autoimmune? That's the major point.
Okay. Do we have more time? There are 3-4 more important questions. Do we have time, Pramod?
No, sir, I think we are almost done because time allotted is now was 45 minutes. We are 10 minutes behind schedule. So unless there is a pressing question, I think we can ask Sudipta.
Okay, if there are no more questions, I am extremely thankful again to Dr. Pramod, Soumya, and all the speakers for a very nice presentation of this uncommon disease called autoimmune pancreatitis. We should understand the limitations of diagnosis because we are still in the naivety of the disease. We need to have a triad of histology, serology, and radiology before we can make a confident diagnosis of autoimmune pancreatitis. I think it is very important for the fellows and the students and of gastroenterology to understand that whenever you're investigating a rare case of obstructive painless jaundice, especially with classical radiological features, please keep in mind a totally treatable disease called autoimmune pancreatitis. With that, I'll hand over the proceedings back to the moderators.
Thank you, Professor Arora, for conducting this session so well. I invite Dr. Sudipta Chaudhary if he is there, or Sudipta, are you there? So let me invite Dr. Samir Mohindra, or Sudipta is here. Sudipta, you can please take over.
Yes, sir. The next session is on recurrent acute pancreatitis. Dr. Samir Mohindra will chair this session, sir.
Samir is Professor of Gastroenterology at SGPGI Lucknow and is an ACE pancreatologist. Thank you, Samir, for joining us today.
Thank you, sir. Good evening, sir. First of all, I want to congratulate you as well as Dr. Sudipto and your whole team for organizing this series of webinar. And I thank you for giving me a chance to be a part of this very interesting webinar. After a very interesting session on autoimmune pancreatitis, now we are on to the second session for today, that is on recurrent acute pancreatitis. As we all know, recurrent acute pancreatitis is a very challenging imaging. Better tools like endoscopic ultrasound, secretary enhanced MRI. Still, it remains a very challenging diagnosis, can avoid a lot of recurrence, which is associated with morbidity and mortality, as well as progression to chronic pancreatitis. And today, the first talk in this session is on approach and diagnostic workup in patients with recurrent acute pancreatitis. And I would like to invite Dr. Sudipto Chaudhary, who is a very eminent researcher, as well as a highly skilled endoscopist, and who has done a lot of work in this field. And I would also request all the participants to pose their questions as the talk evolves so that we can try to answer as many as possible. Over to Dr. Sudipto.
Are my slides visible, sir?
Yeah.
Thank you so much, sir. Thank you for the kind introduction.
Yeah, they're visible.
I'll start off with a story of a young man essay. Now, this is a gentleman I have been seeing since 2012. He was 23 years old when he first came to me. He came in with recurrent abdominal pain once every 1 to 2 months, and since the last 2 years when he first visited me. Each time he required hospitalization and had documented evidence that he had pancreatitis in the form amylase lipase was elevated. He had ultrasound evidence showing acute pancreatitis. So he had no family history of any pancreatic disorder. We did a complete etiological evaluation for pancreatitis, and it was repeated twice actually, and nothing remarkable was found. EUS was done, and it only showed hyperechoic for strands and foci. We did a 72-hour stool fat, and 72-hour stool fat was normal. And this is his CT scan at that time in 2012, which showed a normal pancreas and everything was normal. So having not found anything, we kept him on follow-up. Over the course of next 6 years, his pain gradually decreased in frequency. And 2019, he developed diabetes mellitus. And this is as late as this November 2020. You can see that when he came to see us, he was virtually painless, but he had evidence of chronic pancreatitis in the form of calcifications. Sorry. So Any uncorrected cause of acute pancreatitis can produce recurrent acute pancreatitis. And overall, the risk of a recurrent attack after a sentinel episode of acute pancreatitis is 20%. And recurrent acute pancreatitis is probably the most important risk factor for progression to chronic pancreatitis. Having said this, now what is recurrent acute pancreatitis? Now, variable definitions have been used to define recurrent acute pancreatitis. This is the randomized control trial which came in gastroenterology, and using this, they used a simple definition: two or more distinct episodes of acute pancreatitis with complete resolution of symptoms between episodes. My colleague Sajid from CMC had done this big study on recurrent acute pancreatitis, and he had defined it as two or more documented episodes of acute pancreatitis more than 2 months apart, with at least one of the following: that is, biochemical evidence of acute pancreatitis and features of acute pancreatitis on imaging. Subsequently, in 2012, of course, the INSPIRE group came up with this definition that recurrent acute pancreatitis is defined by at least two episodes of acute pancreatitis with complete resolution of pain of acute pancreatitis more than 1 month between episodes, or normalization of amylase and lipase along with resolution of pain in between episodes. So what we can realize is there is a variability as regards the duration between the episodes is concerned, and that's probably because we really don't know truly when pancreatitis actually resolves. So what are the risk factors? I have just graded it on the size. You can see the font size depicts the weight of this, and most often it's alcohols, smoking, gallstones, genes, microlithiasis, calcium, hypertriglyceridemia, worms. In Sajid's study, which included 188 patients with recurrent acute pancreatitis, the most common etiology was gallstones and alcohol. Of course, hypercalcemia, hypertriglyceridemia, and trauma, ascaris, alcohol and gallstone combination. Biliary microlithiasis was identified in 46 of these patients, and patients who had abnormal pancreatobiliary unions. So a number of risk factors. Now I'll just explore briefly into the different risk factors which have been implicated in the causation of recurrent acute pancreatitis. Let's look at alcohol and smoking. In 2008, when we explored, Perry et al. Looked at this alcohol as a risk factor of a recurrence for alcoholic pancreatitis, and what they showed is that abstinence protects and increased dependency increased the recurrence. In the NAPS2 study, it showed that cigarette as an independent dose-dependent risk factor for recurrent acute pancreatitis. In 2015, another study showed that recurrence is higher in people who smoke, who are alcoholics, who have organ failure after an episode of acute pancreatitis. So what it goes on to show that if a person is has consuming alcohol and smoking and continuing to have recurrent episodes, we should emphasize on stopping these two risk factors. What about the other metabolic risk factors? Calcium is a well-established risk factor for recurrent acute pancreatitis, and this may be falsely negative during an episode of acute pancreatitis. Triglycerides is another risk factor which has been identified as a cause for recurrent acute pancreatitis. Now, there's a problem with triglycerides as regards we really don't know at which point does it produce pancreatitis. All of us are very aware that anyone with a risk of hypertriglyceridemia with a triglyceride level more than 1,000 is at a risk for pancreatitis. But when does the risk actually start off? These are two very large studies which were published in JAMA. This was in 2013 and 2016. This was a hospital-based database including over 30,000 patients. What it goes on to show that the risk factor actually starts to go up above 150 to more than 1.5 times is the hazard ratio. And if it's more than 500, the hazard ratio is about 3.2. This was on a prospective cohort study, which was done in a community over 1 lakh people, and the risk tended to increase above 177 milligram per deciliter of triglycerides. The first study also showed that there was a 4% increased risk of pancreatitis with a 100 milligram per deciliter increase in triglycerides. So in patients with recurrent acute pancreatitis, when all the etiologies have been ruled out, if we find marginal increases in triglycerides, we should endeavor to get it down. Now, what about the anatomical risk factors? This was, of course, a cadaveric study which we had done in collaboration with with the anatomy department, and we identified different types of ductal anatomical variants of the pancreatic duct. The two ductal variants which have been commonly implicated in causation of pancreatitis is the pancreas divisum and ansa pancreatica. Now, I'll just go briefly into ansa pancreatica. exactly what is ansa pancreatica. Ansa pancreatica is basically where the accessory duct has been replaced by an additional curved duct. And this duct arises from the caudal side of the flexion point on the main pancreatic duct, runs caudally at first, and then towards the right and ventrally, and crossing the ventral duct, and finally terminates in the minor papilla. Now, in our series of our patients with recurrent acute pancreatitis, we actually found 3 patients who had uh, ANSA pancreatica. But does it actually a risk factor for recurrent acute pancreatitis? This was a Japanese study which looked at this, and they found that the risk of recurrent acute pancreatitis is higher in the group of patients as compared to a community-based cover group. The risk of recurrent acute pancreatitis is higher in the people who have underlying ANSA pancreatica. The problem is we do not know how to adequately treat it. Does opening the minor duct actually relieve the symptoms? That is not known. What about pancreas divisum? Now, people, 5 to 10% of the people are born with pancreas divisum. 9.1% of chronic pancreatitis have it. And it's both complete and incomplete divisums have been implicated as a cause of pancreas, recurrent acute pancreatitis. But pancreas divisum by itself is not a cause for pancreatitis. Pancreas divisum acts as a partner along with genetic mutations. And this study actually showed it that along with pancreas divisum, there is always existence of either CFTR mutation, which is a very high number, 47% of them had CFTR mutations, or SPINK1 or PRSS1 mutation. So it's actually in conjunction with an underlying genetic mutation that pancreas divisum may produce pancreatitis. So does it help to do a minor duct sphincterotomy? This is probably the only randomized control trial which looked at it, and 19 patients who had recurrent acute pancreatitis were randomized to undergo stenting versus no therapy, and the follow-up interval of 28 versus 31 months. Patients who underwent stenting did not require hospitalization or emergency visit. Subsequently, a systematic review looked at it and found that the pooled success rate of endoscopic therapy in recurrent acute pancreatitis is around 76%. So now coming to the third thing, which is a bit more controversial, is microlithiasis. Now, what is microlithiasis? Microlithiasis is classically defined as stones less than 3 millimeters. This 3 millimeters is primarily used because ultrasound can detect stones more than 3 millimeters, so use a definition of less than 3 millimeters to define microlithiasis. I have highlighted 3 major important Indian studies which have looked at microlithiasis and recurrent acute pancreatitis. First one was from SGPGI India by Professor Saraswat, included 24 patients, the mean age of 36 years. Bile microscopy was abnormal in 18 patients. All of them underwent some form of therapy. At a follow-up of 30 months, most of them were asymptomatic. Professor Garg had done this study in All India Institute, including 75 patients. Bile microscopy was abnormal in 20 patients. But what was interesting in this study is that at a follow-up of a follow-up duration, 10 of them, when followed up, went on to develop chronic pancreatitis. And of the 10, 8 of them actually had undergone cholecystectomy. And none of them actually went on to develop gallstones, which grows into question is that does treatment for biliary microliths actually make a difference? And Sajid's study of 46 patients had microlithiasis, 41 were treated for the UDCA, and 71% of them remained asymptomatic at 1 year follow-up. Of the 71% who remained at asymptomatic at 1 year follow-up, sphincterotomy was done for 25. Of them, 92% remained asymptomatic. Cholecystectomy was done for 4, and at 3 of them, follow-up data was available for 3, and 2 of them were asymptomatic for 3 years. However, 12 of them did not undergo any therapy, and of the 12 of them, 2 of them went on to develop chronic pancreatitis, which goes on to show that a portion of the patients who have documented microlithiasis can go on to develop chronic pancreatitis despite therapy for microlithiasis. So why is there inconsistency as regards the microlithiasis and recurrent acute pancreatitis is concerned? One probably is the techniques in which it was used to identify microlithiasis. Biliary microscopy has a variable sensitivity between 65 to 95%. If you use US, it's a higher sensitivity. But when should we suspect microlithiasis? Now, this is a very old paper, 1999, which actually showed that if you have an early rise, within 24 hours rise of aminotransferases after the onset of pancreatic pain, then only one should suspect microlithiasis as a cause for recurrent acute pancreatitis. Coming back to tumors, in an elderly person, especially above 50 years, coming with a new onset recurrent acute pancreatitis suspect tumors. This is one of our patients, 56-year-old gentleman, had recurrent acute pancreatitis, 3 episodes. Imaging was not consistent. We did an EUS. This is an EUS image actually. Papilla was normal, but at EUS, what we could see was there was this bulge which is protruding into the main pancreatic, and main pancreatic appeared dilated. We went ahead and did an FNAC of this, and this showed pancreatic adenocarcinoma. Medications. Medications are another host of drugs which we fail sometimes to identify, but a host of medications have been identified as causations for pancreatitis. And this is just a list of the class 1 medications which have been implicated in pancreatitis. So a good history of medications that the person is taking may identify a cause in an individual. But I think the most important, especially in an Indian context, when we see more of idiopathic early onset pancreatitis, the reason is genetics. And Dr. Podar has done his study on idiopathic recurrent pancreatitis, looked at 3 genes and identified SPINK1 mutations in 45% of the patients. This is a Chinese study, included both chronic pancreatitis and recurrent acute pancreatitis, and looked at 10 genes, and 65% of them had more than one mutation, and 18% had more than one gene affected. Now, this is from Asian Institute of Gastroenterology. Again, all 6 genes were looked at, 89% had one gene mutation. So a sizable proportion of our patients with idiopathic recurrent acute pancreatitis have underlying genetic mutations. And we'll probably hear later in the day about the genes involved. So can recurrent acute pancreatitis progress to chronic pancreatitis? A number of studies, including the one that I was alluding to, Professor Pramod Garg's study, which showed that 10 of them had actually gone to microlithiasis, had went on to progress to have chronic pancreatitis. Another study from Cochin showed that 10 patients went on to 28 patients recurrent pancreatitis, 10 of them went on to progress to chronic pancreatitis, and median time of progression was 1.7 years. From Manipal 2016 paper, 44 patient recurrent pancreatitis, 15 of them went on to develop chronic pancreatitis with a progression time of 20 months. Dr. Poda's study in 2017 identified the risk factors, and probably the most important risk factors that they identified was an idiopathic risk etiology, SPINK1 duration, and of course, when you follow them up for a longer period of time, you would identify chronic pancreatitis. The INSPIRE group also identified that recurrent acute pancreatitis can progress to chronic pancreatitis, and the rate of progression is faster in people in children who have disease onset after 6 years of age and have a pathogenic PRSS1 mutation. So how do you identify chronic pancreatitis? And there are different modalities that one can use it, but obviously the most sensitive of them being EUS or ERCP, and EUS being slightly more safer than EUS, definitely more safer than ERCP, as more really the preferred modality of choice. And Vikas is going to speak more in detail about EUS and recurrent acute pancreatitis. I'll just go briefly into 2 studies from our center, which had looked into this aspect of it. This is Ramit's study, which had 71 patients with recurrent acute pancreatitis, younger age group. They were identified, definitive evidence of chronic pancreatitis was identified in 28%. Rubin study in 2019 had 154 patients with idiopathic recurrent acute pancreatitis, a slightly higher age group, but definite evidence of chronic pancreatitis was identified in 24%. So is there a stage that we can identify before EUS changes come in? Of course, that requires histology. And the critical step to identify progression from recurrent acute to chronic pancreatitis is development of fibrosis. And histology is rarely available. So we have to look at surrogate markers like stiffness of biological tissue as a marker for fibrosis. And elastography is a useful modality, and it has been used in liver, in breast, etc., to look at fibrosis. One of the modalities that we can use is called acoustic radiation frequency impulse imaging. Now, this is a form of shear wave elastography where high intensity acoustic radiation force is used to displace tissue, and shear waves travel in a direction perpendicular to the force of the ultrasound waves. And the ultrasound machine calculates the velocity at which this shear waves travel, and stiffer the tissue, the greater the speed and higher the shear wave velocity. One advantage of the RF imaging over traditional elastography is that it can focus on a particular region of interest and therefore can be used to target a deep-seated organ like pancreas. Multiple studies, mostly have come in from Japan, showed that there is a significant correlation with shear wave velocity and pathological fibrosis. There's all post-operative studies which show that shear wave velocities correlate very well with pathological evidence of fibrosis. Using this evidence, we did this study, which included 31 patients who had idiopathic early onset recurrent acute pancreatitis and 31 control individuals who did not have. We did we did MRI, EUS. Both of these patients did not have any. The idiopathic recurrent acute pancreatitis did not fulfill the EUS criteria for chronic pancreatitis. The control group included a group of patients who underwent EUS for an alternate indications. What we did find was that the shear wave velocity was definitely much higher in the idiopathic recurrent acute pancreatitis as compared to the controls. And the shear wave velocities continued, there's a linear relationship between the number of episodes of pancreatitis and the shear wave velocity, showing that as the number of attacks increases, the fibrosis keeps on increasing. So to summarize, what we would say is that we start off with the liver function test, lipid profile, serum calcium, and ultrasound. And of course, before that, of course, a good history looking at drugs, smoking, alcohol, and family history, do liver function test, lipid profile, serum calcium, ultrasound. We're doing to follow it up with an MRI to look for mass, stone, changes of chronic pancreatitis, pancreatic abnormalities, CT scan, and EUS. And if possible, couple it with an RF and genetics. I'll go briefly to the therapies which are currently available for this group of individuals, especially idiopathic recurrent acute pancreatitis. Of course, if you have an etiology, treat the etiology. If there's alcohol, we treat the alcohol and smoking. If they're hypertriglyceridemia, lower the triglycerides and calciums. What is the role of ERCP? This is a study which was a randomized control trial in patients who had normal sphincter 40 manometry and elevated sphincter and sphincter 40 dysfunction. Basically, there was no difference in the efficacy of sphincterotomy, and recurrence of pancreatitis in patients who had normal sphincter 40 was similar who had underwent a sham procedure or a biliary sphincterotomy. So the most common indication for people who undergo ERCP in recurrent acute pancreatitis is either there's an obstruction or there is a pancreas divisum. This is a survey amongst gastroenterologists, and the more common indications for ERCP in patients with idiopathic recurrent acute pancreatitis is when there is a pancreatic dilatation or symptom, along with symptoms and a pancreas divisum. Lastly, what are the role of antioxidants? This is a study from AIIMS which looked at patients with idiopathic recurrent acute pancreatitis have high oxidative stress and they have low antioxidant levels. And Dr. Ganesh Pai from Manipal in his study has shown that when treated with a combination of medical therapy complaining of pancreatic enzymes and antioxidants in IRAP had obtained a 53.9% response. To summarize, what I would say is acute pancreatitis can progress to recurrent acute pancreatitis if the etiology has not been identified or treated. Structured evaluation is what is required for identification of treatable conditions. And in a person, more than one etiology can exist. For example, smoking and alcohol, you have pancreas divisum along with genetic abnormalities. And if no definite cause is identified, we should consider genetic testing because that would bring a stop to his further evaluation. And recurrent acute pancreatitis have underlying fibrosis, and we should keep in mind that they can progress to overt chronic pancreatitis. Thank you so much.
Dr. Pramod, can we take the questions related to this talk or we take it at the end?
I think it depends. Maybe you can finish off the talk by Dr. Vikas Singla and then go for questions because both are related topics.
Okay.
Some of the questions might be actually covered in his talk.
As you say. So our next speaker is Dr. Vikas Singla. He's a senior. Okay. So now I would like to invite Dr. Vikas Singla. He's an associate professor at GRI PMER. He's a senior consultant in Department of Gastroenterology, Sir Gangaram Hospital. He's a very well-known endoscopist, and he'll be speaking on role of EUS and recurrent acute pancreatitis. Over to Dr. Vikas. Yeah.
Thank you, Dr. Samir. At the outset, I'm thankful to my mentor, Dr. Pramod Garg, my friend Sudipto, and Soumya for the kind invitation. And Sudipto has already discussed about the recurrent acute pancreatitis. I will be discussing the role of EUS in recurrent acute pancreatitis. Uh, are my slides visible?
Yeah, they're visible.
So I think recurrent acute pancreatitis is a very important clinical problem, and it's very essential to detect the etiology so that we can prevent the future attacks. Because if we don't find any etiology, there is very high chance of recurrence. After a single episode of idiopathic acute pancreatitis, the relapse is 20%. And after multiple attacks of idiopathic pancreatitis, the recurrence rate is around 50% at 3 years. As EUS provides excellent resolution of pancreas and the biliary system, EUS can be an important modality to detect the etiology of acute pancreatitis. So these are the causes of acute and recurrent pancreatitis. The causes on the right side, they can be detected with the EUS. We can detect biliary stone and the microliths. We can detect anomalous pancreatobiliary union, choledococele, annular pancreas, autoimmune pancreatitis, and pancreatobiliary tumor divisum SOD. And the condition mentioned in the blue, they are the debatable cause of acute pancreatitis. Sphincteroid dysfunction, annular pancreas, divisum, whether they lead to acute pancreatitis or not, it's a debatable issue. Other condition, they definitely lead to acute pancreatitis. And if we can detect this condition on EUS, we can treat and prevent the further attack of pancreatitis. So on EUS, we should look for the microlithiasis or the stone in the gallbladder or the common bile duct. We should look for the small pancreatic neoplasm, which are missed on other imaging modalities. We should look for the pancreas divisum, ampullary tumor, or the biliary ascaris. So when we are doing the endoscopic ultrasound for the recurrent acute pancreatitis, we should always see the pancreatic ductal finding. Here we can see the PD from the stomach, and we can see PD and the common bile duct. They are opening at the major papilla. In this case, we could see the major papilla from the stomach. Next is the examination from the D2, and here we should again try to trace the duct from the ampulla. So we can see CBD and the dorsal duct is opening at the major papilla, and we are able to trace the duct to the body and tail of the pancreas. It means the dorsal duct is opening at major papilla. This rules out the pancreas divisum. Then we should evaluate the body and tail of pancreas for hyperchoic strands, foci, lobularity, or the small tumor or the calcification. So we should look for the microlithiasis, any small tumor, or the changes of chronic pancreatitis while doing the endoscopic ultrasound. From the D1 or the antrum, we should see the gallbladder, and we should look for the small stone or the sludge in the gallbladder. So in this patient with the recurrent acute pancreatitis, from the first part of duodenum, we could see gallbladder is filled with the sludge, and in between the sludge, we can see small microliths with the shadow. So they are definite small stones, and they can cause the recurrent acute pancreatitis. Another patient who had recurrent acute pancreatitis, and we could see a small tumor at the ampulla, and the FNA showed it's a adenocarcinoma. So we should look for malignancy, we should look for changes of chronic pancreatitis, we should look for the small stones. And either the conventional criteria or the Rosemont criteria can be used to diagnose the chronic pancreatitis. Now the next question is whether we should do EUS after a single episode or multiple episode of acute pancreatitis. So this is a study by Dr. Sahay's group, and in this study, there were 360 patients, 246 patients, there was gallbladder in situ, and 124 patients, it was done after the cholecystectomy. So out of 246 patients who had gallbladder in situ, 12 patients, they had recurrent pancreatitis, and 134 patients, they had single episode, and the standard investigation, as mentioned by Dr. Sudipto, were normal, and EUS was done to evaluate the etiology. We can see that the gallstone was a common cause, stone and sludge. It was seen in 20% of patients who had gallbladder in situ, and pancreas division was seen in 5 to 10% of patients, and pancreatic malignancy was a rare cause seen in around 1 or 2% of cases. Overall, EUS could detect the etiology in 31% of patients who had a single attack of acute pancreatitis, and 32% of patients who had a recurrent attack of pancreatitis. So even after a single episode of acute pancreatitis, when the standard investigation are normal, EUS should be done to find out the etiology. Very interestingly, patient who had a single episode, already 21% of patients, they have underlying chronic pancreatitis, and patient who had multiple episode, 42% of patients, they already had a chronic pancreatitis. Overall, EUS could establish the etiology in 50% of patients with the primary episode, and 75% patient with the recurrent episode of acute pancreatitis. And this is a meta-analysis published this year, 28 studies, 1850 patients. Out of these, 47% of patients, they had multiple attacks of recurrent acute pancreatitis. And out of these, 37% had CT already done and MRCP in 15%. But there was no cause found for the cause of acute pancreatitis. After endoscopic ultrasound, the biliary etiology was seen in 37%. Out of these, 32% were microliths. All these patients had already done the ultrasound once or twice. There was no stone on the ultrasound. So EUS could detect microlith in 32% and CBD stone in 5%. Very interestingly, after the treatment, the recurrence rate was only 2% at 2 years. It means that biliary etiology was truly diagnosed and it was a cause of acute pancreatitis in the patients. And out of total around 1850 patients, 21% of patients, they have already chronic pancreatitis. 6% of patients, they have pancreatic neoplasm, and 40% of patients, there was no abnormality. And this was a study from Dr. Sham's group, again, EUS in idiopathic pancreatitis after single or multiple episodes. After a single episode, the most common cause was the idiopathic in 53%, and 15% of patients, they had microliths and the pancreatic. In this patient, the author also performed the sphincter foci manometry, MRCP, and they postulated that sphincter foci dysfunction is a etiological factor in 40% of patients who had multiple attack, and 16% of patients with a single attack had pancreatic divisum as a cause of acute pancreatitis, but this is a debatable condition. And chronic pancreatitis was seen in 11% of patients after single episode, and 10% of patients with multiple episodes, and 7% of patients, they developed chronic pancreatitis during the follow-up. And in all the patients with the sphincter foci dysfunction and pancreatic divisum, they underwent endotherapy, but the response to treatment was poor. 50% of patients, they have recurrence of acute pancreatitis even after the endotherapy for these conditions. And all the patients with the cholelithiasis or microlith, they were offered surgery. The recurrence rate was 8% after single episode. On the other hand, the patient who had multiple attacks and were diagnosed as cholelithiasis or microlith, the relapse rate was very high in 25%. The relapse was higher in pancreatic divisum and the sphincter foci dysfunction. In patients with idiopathic pancreatitis, the relapse was very high, 20% after single episode and 47% after multiple attack of acute pancreatitis. And this is Indian study from the PGI Chandigarh, 40 patients, 26 male, and 23% had single attack and 17 patients had 2 attacks of acute pancreatitis. 50% of patients, they were diagnosed as biliary tract disease, either CBD sludge, cholelithiasis, gallbladder sludge, or the CBD stone. All these patients underwent either surgery or ERCP, and there was no recurrence in all these patients. One patient had pancreatic tumor, one had pancreatic divisum. Out of 45% of patients where no cause was found, 9 patients were thought to have chronic pancreatitis based on the conventional criteria. And out of 9, 2 developed calcification during the follow-up, and 9 had the normal pancreas on the EUS, and all the patients remained well. So if in patient with idiopathic recurrent pancreatitis, the pancreatic parenchyma is normal, there are less chances of recurrence of recurrent acute pancreatitis. Now, this is an excellent study from the AIMS group. This is regarding whether microlith really leads to pancreatitis. In this study, out of 75 patients, the mean age was 31 years only. These were the young patients. 80% of patients were male. And they already had a mean duration of illness 30 months, and they already had 4 to 5 attacks. So it was later in the course, and they were followed up for a mean follow-up of 18 months. And in 18 patients, no cause was found, and 47% of patients, they developed chronic pancreatitis during the follow-up. It means that young male having recurrent acute pancreatitis, they are likely to develop chronic pancreatitis. Very interestingly, 20% of patients, they had biliary crystal on the bile analysis, and all these patients either underwent surgery or the ERCP. Out of 20, only 5 were symptom-free, 7 were lost to follow-up, and 10 developed the chronic pancreatitis. So surgery was curative only in 5% of patients who were diagnosed with microlithiasis. So only 25% they had truly the biliary disease. So why this is the result? Why the patient haven't responded to the surgery for the microlithiasis? The answer comes from the another study which was published in 1991. in this study, idiopathic acute pancreatitis patient, they underwent the bile analysis, 64 patient, 104 episodes, and they had recurrent acute pancreatitis. But here they were female and age was 62, elderly female. And bile microscopy showed the crystal in 67% of patients, 34 patients, they had abnormal bile analysis. Out of 34, 33 patients developed the stone on the ultrasound at 1 year. It means if the patient has truly the biliary disease at as etiology, at 1 year, most of the patient, they should develop the gallbladder stone. So if we compare two studies, in the study by Ross et al., 64 patient, mostly female, elderly female. By a study by Dr. Garg, 75 patient, mostly young male. Duration of illness, 30 months here, it's less than a year. Number of episode, 4.8, 1 to 2 here. So that's why these patients had truly the biliary disease, because if they had to develop stone, they will develop stone within a year. These patients, despite of a follow-up of 3 years, nobody had stone on the ultrasound. They just had microlithiasis on the EUS or the bile crystal analysis. If these patients had truly the biliary disease, they should have developed the stone on the ultrasound. So this cartoon shows that in a patient who comes early in the natural course, yellow one is the biliary etiology, and the gray is the chronic pancreatitis, green idiopathic, and blue is the neoplastic. So this is the true etiology. So after first episode of acute pancreatitis, if we do endoscopic ultrasound, we can detect the microlith will be the most common etiology, and it will be the true etiology, and patient will respond to treatment with the gallbladder surgery. Few chronic pancreatitis can be picked up because they are coming early in the course. There may not be significant changes on EUS for the chronic pancreatitis. In idiopathic, the pancreatic parenchyma will be normal, and the EUS can pick up most neoplastic lesion. So if we do EUS in the early course, we can pick more microliths and the neoplasia. Late in the natural history, after 3-4 episodes, most of the patient will microlith, they will develop stone, and which can be detected on the ultrasonography. So here the most common etiology late in the course will be either chronic pancreatitis or the idiopathic pancreatitis. There will be few neoplastic or the few biliary cause. So if we do endoscopic ultrasound here, we can pick up more lesion with the chronic pancreatitis. So that's why the study by Dr. Garg showed that the chronic pancreatitis is the most common etiology late in the course, and other studies showed that the microlith is a common cause during early in the course. Another indicator of biliary pancreatitis is the ALT level. So whenever patient of acute pancreatitis asks me that whenever he has a next episode, which investigation he should do, I always tell them do liver function test, because if the liver function tests are transiently elevated, if there is transient elevation of ALT during the 48 hours of next attack, it strongly suggests that there is a chance of biliary etiology. In a study of 68 patients, the ultrasound EUS and the postmortem study was used as a gold standard for the biliary etiology, and 44 patients had a true biliary etiology, and combination of ultrasound and the liver function test could detect all the cases of true biliary etiology. EUS could add only one case of microlith. So patient with the acute pancreatitis should always undergo LFT within the 48 hours, and the ultrasound, they will pick up most biliary causes by this combination. Now coming to the pancreatic divisum, is pancreatic divisum a true cause of chronic pancreatitis? Many times in a patient with chronic pancreatitis, on endoscopic ultrasound, we see there is a pancreatic divisum. Is that a cause of chronic recurrent acute pancreatitis? So in this study by Ames, the authors look for the mutation in patient with the pancreatic divisum and the idiopathic pancreatitis, and authors found that the SPINK mutation was similar in patient with the chronic pancreatitis, recurrent acute pancreatitis without pancreatic divisum, and patient with the pancreatic divisum and pancreatitis. And authors postulated that pancreatic divisum by itself cannot lead to recurrent acute pancreatitis or chronic pancreatitis. It needs a cofactor in the form of genetic mutation to lead to chronic pancreatitis. Similar study from the another author group, the author looked for pancreatic divisum in the patient without pancreatic disease. The prevalence of pancreatic divisum in patient without pancreatic disease was 7%. 7% of patients with the alcohol-induced pancreatitis had pancreatic divisum, and patient with the genetic mutation had a high chance of pancreatic divisum. CFTR mutation, out of these patients, 47% had pancreatic divisum. It indicates that pancreatic divisum by itself cannot lead to recurrent acute pancreatitis. There should be associated genetic mutation for pancreatic divisum to lead to chronic recurrent acute pancreatitis or chronic pancreatitis. Whether endotherapy of pancreatic divisum will lead to response for the pain or the recurrent attack, it's a debatable issue. Now, comparing EUS with the MRCP, a large systematic review has shown that if you compare EUS and MRCP, EUS can pick up more biliary causes, EUS can pick up more microlithiasis, and EUS can diagnose more chronic pancreatitis. On the other hand, secretin enhanced MRCP is superior to EUS for detection of pancreatic anomalies such as pancreatic divisum. So EUS and MRCP are complementary in a patient of recurrent acute pancreatitis. So to summarize, EUS is an important tool for evaluation of recurrent pancreatitis, microlithiasis, pancreatic divisum, and the chronic pancreatitis are the most common findings depending on the cause. EUS findings should always be interpreted in the context of clinical presentation. Young male with the long duration of disease are likely to have chronic pancreatitis. If this patient had microlith, one should always look for the liver function test. If ALT are increased during the acute episode, this patient will improve with the lab cholecystectomy. Middle-aged female is likely to have biliary etiology, and ALT levels are important for the decision making. Thank you very much for your patient hearing.
Thank you, Vikas, for an excellent overview. And the time was short, so you had to cover limited things. First of all, there are certain questions. First, for Sudipto, is it logical to think that most of the cases with moderate pancreatitis, is there a correlation of severity of pancreatitis in the first attack and evolution into chronic pancreatitis? Sudipto?
Sorry, sir, if I just, there's a bit of a network issue here, so I'll just rephrase the question.
Please repeat that.
Yeah, can you?
Is it logical to think that if there is severe acute necrosis, more likely vis-a-vis acute interstitial pancreatitis, where chances are less? The correlation of severity of pancreatitis in the first attack and evolution into chronic pancreatitis over time.
Yes, sir. It is very well known that when there is a severe yes, sir. When there is a very severe episode of acute pancreatitis, we have what we call the sentinel acute pancreatitis event also. In those events, when there is a very severe episode of acute pancreatitis, then the healing process would always lead on to either fibrosis or an ectopic. So it depends on either the severity of the attack or the frequency of the attack. The more severe the attack, end result will be a chronic pancreatitis. More the number of attacks, end result will again be chronic pancreatitis.
Second question was, is there the relationship of how much and for what time amount of alcohol intake which decides that patient may evolve into recurrent acute pancreatitis? Basically, the question is there a threshold of the amount and the duration where chances are that the person will evolve into recurrent acute pancreatitis, and possibly person drinking a little less or for a shorter duration has less chances of recurrent acute pancreatitis? That is the question, I think, what the...
I get the question. Well, it is assumed, sir, that if a person drinks around 80 grams of alcohol for around 5 to 6 years, the risk of alcoholic pancreatitis is high. Having said this, the relation is not as good as you see in alcoholic liver disease. Vis-a-vis, only 5% who are chronic alcohol consumers actually go on to develop alcohol-related pancreatitis. So the relationship is not very linear. Of course, there's also, we have to look into it, the alcohol along with smoking increases the risk further. Alcohol and tobacco have got both what you call a dual effect on the pancreas, and both of them may increase or shorten the duration before which a patient can develop chronic pancreatitis.
One more question on genetic testing.
Sir.
Does single gene mutation can also evolve into recurrent acute pancreatitis and possibly chronic pancreatitis? See, most of the studies had looked at panel of mutations. If there is single mutation found with no other confounding factor, no other etiology, Do you think that can also predispose the person to recurrence of pancreatitis or possibly evolution to chronic pancreatitis?
I am not an expert on genetics. I wait for Dr. Divine.
Yeah, that would be better. Yeah,
Having said this, I would like to put my 2 points on this, sir. The one thing is, what all the studies have done is the candidate gene approach. They have chosen candidate genes, 6, 7, 10 genes, and run the panels and identified particular genetic mutations. When such a study approach is used, you might find one mutation, you might find two mutations. A person may have multiple mutations, which may be either disease-causing mutations or disease-modifying mutations. So to say we have identified one mutation and to do it, we really don't know the answer to that question. So identifying a single gene mutation and attributing everything to that may be kind of very difficult.
Okay, and question for you. What is the advantage of diagnosing early chronic pancreatitis in patients with recurrent acute pancreatitis?
I think it has got
very interesting questions. Difficult to answer, but logical thinking.
I agree. I agree. The question may not be relevant as of yet in today's circumstances, but I'll bring it up to the context in which we are looking at. Chronic pancreatitis is an end-stage disease where the organ is beyond a point of repair. If we are able to find a disease where the structural changes in the ducts and fibrosis has not progressed to a point of significant damage, then maybe at a later point of time, therapies may emerge which can look at fibrosis. The second point being antioxidant therapies. Idiopathic recurrent acute pancreatitis, you would understand, sir, has no definitive therapy. It is like basically we cannot offer endoscopic therapy. Enzyme therapies are not required because the patients do not have enzyme insufficiencies. Antioxidant therapy, as Dr. Ganesh Pai has shown, has got a significant benefit. We've had one work which we submitted to DW this year, which showed that using antioxidants, we were able to get a 50% reduction in pain frequencies in people who are otherwise suffering from recurrent acute pancreatitis. So I think that's one big advantage with this.
Now, let me also come in and just give a comment about this. I think there are two issues why it is important to find out if it is early chronic pancreatitis or not. One, from a prognostic point of view, you know this patient is likely to have a prolonged disease course running into years. That's one. And second is, when you say recurrent acute pancreatitis, everybody is looking for a cause. Somebody will say macular, somebody say triglyceride, somebody say drug, and patients running around from pillar to post to find the cause, right? The moment you say it is chronic pancreatitis, you end there and say either it is alcohol or it is genetic, mostly. That is one important thing why I think it's important to find out whether it is dealing with RAP or early chronic pancreatitis. Although most of the time, as both these speakers have very elegantly highlighted, that we are looking at a stage of the disease where the patient is presenting with recurrent acute pancreatitis, but ultimately these are the patients who will likely end up having chronic.
There are two questions for Vikas. Vikas, what are there any features specific of sphincter of Oddi dysfunction which you can pick up on EUS? This is one question.
Yeah, that's a very good question. I don't think as of today there are EUS criteria for SOD, but I think one indicator can be if we have dilated duct till the papilla and there is abrupt termination of the duct and there is thickening, symmetrical thickening of the papilla, but we don't see any mass. That can be one of the indicator. But as of today, we cannot diagnose SOD by the endoscopic ultrasound.
Thank you. Second question is there a role of bile assessment, that is bile microscopy, as of today?
Yeah. Samir, when we are doing the bile assessment, we are looking for the crystals in the bile. Okay. And we assume that they are the surrogate markers for the microliths or the gallbladder. Crystal per se, they cannot cause the acute pancreatitis. There has to be either a microlith or the gallstone. Earlier, we did not have EUS, did not have a good modality for the microlith. So we were looking for the bile analysis and we were assuming that if the patient has bile crystal, that patient must be having the microlith. But now we have a very good tool. EFC is excellent tool for the detection of microleaks. So I don't think there is any indication for the bile assessment. We can do endoscopic ultrasound for assessment for the microleaks or the small stones.
So one question from my side. If you have a patient with recurrent acute pancreatitis and you have to choose between MRCP and US,
Yes.
and you don't have any evidence of any ductal abnormality. See, MRCP will score over US in a subset where ductal abnormality has to be seen, whether the bile duct or pancreatic duct. So which investigation you will choose if you have to choose one? Because with person with limited resources,
Yeah.
and cost is always a factor. So in a patient with recurrent acute pancreatitis, which second line investigation you will do? MRCP versus endoscopic ultrasound when only one is possible.
Yeah. The most common cause for the recurrent acute pancreatitis is either microleaks or it can be early chronic pancreatitis. Both the diseases are better diagnosed on endoscopic ultrasound. So my preference will be endoscopic ultrasound over the MRCP.
Dr. Pramod, we don't have any more questions. So I thank both the speakers. They were excellent overview of the topics allotted to them. And now over to Dr. Pramod.
Thank you, Samir. Thank you, Sudipta and Vikas, for enlightening talks about recurrent acute pancreatitis, diseases which are very commonly seen, and often the clinician is, he doesn't know what to do, and patients and parents keep asking what is the problem, how do you treat it? So I think today's webinar on recurrent acute pancreatitis should definitely help physicians and gastroenterologists treating these patients. So thank you all very much. Now I invite Dr. Rohan Malik, who is professor of pediatric gastroenterology at All India Institute of Medical Sciences, and he's someone who is holding the fort at AIMS whenever it comes to pediatric pancreatitis. And I hand over the mic to Rohan for the next session.
Thank you, sir. Good evening, all. Welcome to this wonderful webinar. So the next two topics are very interesting. The first topic, the speaker is Professor Ujjwal Podar. He is one of my mentors and he is the head of department at one of the premier pediatric gastroenterology center in India, is Sanjay Gandhi PGI. And he's going to talk about pediatric chronic pancreatitis. And Professor Podar has an extensive body of publications on pediatric chronic pancreatitis. So, sir, please request you to start your talk.
Thank you, Rohan. Is my slide visible?
Sir, it's visible. Can you go to full screen?
Yeah, I'm trying to. Slideshow.
Sir, bottom of the screen, right hand corner.
Yeah, that is not working. Slideshow. No. Any other suggestion how to go to the slide? I'm trying with the slideshow. Yeah, now it will come from the beginning. Yeah, got it.
Yes, sir.
Rohan, is it correct?
Yes, sir. Fine,
okay.
Sir, it's fine.
Thanks, Rohan. At the onset, I must thank Indian Pancreas Club, especially Sudipto and Pramod for giving me this opportunity. I have been given the task of talking about pediatric chronic pancreatitis. So, with a whole lot of information, what I'll do, instead of repeating everything, I'll talk about those areas where pediatric chronic pancreatitis is different from the adult. So let us start with the definition, then we'll go to the etiology, what are the difference between adult and pediatric chronic pancreatitis, and prevalence of comparative prevalence between pediatric and adult. And I will go to this, the continuum of AP, ARP, and CP, some clinical differences and management issues. Sorry. So this is a group, international study group of pediatric pancreatitis in search for cure. This group was formed mainly in the North America with 15 centers of America and Canada, and they have come with this definition. So we call it the inspired definition in children. So for what is chronic pancreatitis, you should fulfill one of these three. This is almost same like adult. You need to have pancreatic type of pain with imaging findings suggestive of chronic pancreatitis. Other two are important in pediatric practice. We can have a child simple exocrine endocrine insufficiency, but without any imaging evidence, then this is not chronic pancreatitis. Like we have pancreatic hypoplasia, aplasia, some syndrome, there you get the exocrine pancreatic insufficiency mainly, but they don't qualify to be labeled as chronic pancreatitis. Similarly, if you have endocrine insufficiency, like if you have a type 1 diabetes mellitus, a child can have T1 diabetes mellitus without imaging evidence, which is not. On the other hand, if you have imaging evidence with endocrine insufficiency, then it is type 3C diabetes mellitus, or it is a chronic pancreatitis diabetes mellitus. So this is the definition of pediatric chronic pancreatitis. Now come to the etiology. What so far we are discussing about the in adult, whether it is acute recurrent or it is chronic, either it is gallstone, alcohol, or smoking. But in children, it is a whole lot of genetics. When we talk about the pediatric chronic pancreatitis, this is the data of INSPIRE group, 146 chronic pancreatitis children, and they have shown the 73%, almost 3/4 of kids, they have one of the other genetic mutation, and as has been highlighted, in the West we get more often TRSS mutation, but in India we get more of a SPINK. You can get a obstructive cause around 1/3 of cases. Again, coming to the pancreas, division, pancreatobiliary anomaly, etc. Toxic or metabolic causes is around 16%, mainly again the smoking, drugs, hypertriglyceridemia, and autoimmune a subset of patients. But what is interesting is that if you look for etiology, almost 86% of the cases you get one or the other etiology. So what we used to call is idiopathic chronic pancreatitis, that has shrunk to just 14%. And very interestingly, almost a quarter of patients have multiple etiologies. And what are these multiple? Like just we heard the talk about this pancreas division with genetic mutation. So many of these cases where you have some other obstructive or toxic, you have underlying genetic factor is also present. Now, what about the Indian data? We have two large series. One is from CMC Vellore, the Chaudhary et al. Series of 99 cases of chronic pancreatitis in children. And we have published our study of 156 cases of chronic pancreatitis a couple of years back. Now, if you look at the etiology, what we used to call idiopathic, what is idiopathic? When you're looking for obstructive or you're looking for a stone disease or something like that, alcohol, and rest are idiopathic. Actually, nowadays, idiopathic means once you rule out the genetic cause, then only it comes to be idiopathic. So, as usual, if you don't do genetic mutation, 80 to 90% of chronic pancreatitis are idiopathic. Obstructive like pancreas division around 6 to 8%, post-traumatic around 2 to 4, or familial hyperlipidemia. But a subset of patients we managed to do 40 out of these 156 genetic mutation. We have shown that 55% of idiopathic chronic pancreatitis, they have underlying genetic mutation. Now, what is this mutation prevalence in chronic pancreatitis in children? Now, if you do on what we have done, the three genes, mainly serine protease, trypsinogen, and CFTRI, and we got 55% predominant SPINK mutation, like in the adult studies in India. The SPINK is the common mutation. INSPIRE group, they use the 4 gene. They added CTRC2, PRSS1, SPINK, and CFTRI. They got 73%, and PRSS1 being the commonest. From the China, Wong et al. In 75 cases, they have used 5 genes. So you keep on increasing the number of candidate genes, and you are getting more cases, 67%. But in the China also it is a SPINK one. And the latest study from China, they have used next generation sequencing, used 10 candidate genes, and they got 82% had one or the other. But remember, coming back to the basic genetic problem, is the PRSS1, SPINK1, CFTR. These three are more common. You keep on adding, you get some of the other, but predominant gene remains these three. So one question was asked, what is the purpose you are going to serve by doing the genetic testing? So basically, what people believe now, at least in pediatric chronic pancreatitis, this is a continuum of the disease. It starts with acute, then goes into a transition phase called acute recurrent, and then chronic. And what is the driving force? It is probably the genetic predisposition. If a child with idiopathic acute pancreatitis has genetic predisposition, his chance of going to recurrent acute, and even in the recurrent acute, idiopathic, you don't have any structural cause, no microlithasis, no gallstone, no obstruction, then his chance of going to the chronic is high because he has the genetic predisposition. So if you detect a mutation, what you can do? We can take some preventive steps, like a child is going to become adult. We can take lifestyle modification, which can predispose this child to accelerate the course of the disease, like alcohol, smoking can be avoided. And in future, we don't know that there may be a development, we can halt the progress of the disease by some way or the other. So as we are talking about, this is not a separate component, acute, recurrent, or chronic. Probably this is a interplay. Almost 30% of acute goes into recurrent acute, and Pramod has shown half of them are going into the chronic. So this is interesting. The study published almost 10 years back from Germany. What they have done, they have analyzed this genetic marker in 780 chronic pancreatitis in adults. And they found that 139 of them have either SPINK or PRSS1. And then retrospectively, they collected the data. And what is interesting finding is that all these patients who has this mutation, either SPINK or PRSS1, the first time they had an acute pancreatitis at the age of 12 or 13 years of age. Now, what happened next? Next, over the next 15 to 20 years, that if it is a SPINK positive, 80% of them develop features of chronic pancreatitis in terms of ductal dilatation, calcification, or insufficiency. And this figure is 50% in PRSS1 mutation. And what they have shown that the speed of developing chronic pancreatitis is faster in SPINK1 than PRSS1. We have done this study and published 5 years back. Our hypothesis was that if it is a idiopathic acute or recurrent acute, probably genetic mutation that leads to the chronic pancreatitis. We have taken 3 groups of children, idiopathic acute, recurrent acute, and chronic. And there is clearly clustering of the gene in the recurrent acute and chronic, almost half of them. But 25% of children with idiopathic acute also had mutation, and predominant mutation was SPINK and CFTR. But what is the interesting part is that on follow-up, those children who had mutation over a follow-up of 40 months, 5 of the 8, 62% developed chronic pancreatitis compared to just 1 out of 16 who didn't have any mutation. In the recurrent acute, in children we call it ARP because RAP means the recurrent abdominal pain. So in acute recurrent pancreatitis group, again, over a follow-up of 4 years, 6 out of 9, 67% developed chronic pancreatitis versus just 16%, and this difference was significant. So this is a study published just last year from the Cincinnati. They substantiated the fact what we are trying to say, that in acute or recurrent acute pancreatitis, that the progression depends on underlying genetic mutation. They have done this mutation analysis in AP, ARP, and CP with a follow-up of 3.3 to 5 years. What they have shown that progression to chronic pancreatitis is faster when there is one of the other mutation versus those children who didn't have mutation. And the SPINK1 was associated with the faster progression compared to other mutation like PRSS1 or CFTR mutation. And if you have this is gene dose phenomenon, if you have 2 gene mutation, then progression was faster versus the 1 gene mutation or no mutation. So what is this data suggesting? That idiopathic cases of acute, recurrent acute, if you have a mutation, that probably predicts the outcome as in terms of developing chronic pancreatitis. And the more the gene mutation, more faster the progression. This is a huge database. This is published gastroenterology 2 years back from USA from a private insurance company who has collected the data for both inpatient and outpatient of pancreatitis over 2007 to 2014. It is mind-boggling number. 4,26,000 cases of acute and chronic, and they have subdivided pediatric and adult cases of acute and chronic pancreatitis to see what is the incidence. Now, what is their data is showing the incidence of pediatric chronic pancreatitis in North America was 2.2 per 100,000 population, and which has reduced just marginally to 1.9 per 100,000 in 2014. But compared to the adult data, it was 32 per thousand, which has reduced to just 25. So why there is a difference that over that 7 years period, there's a significant reduction of the incidence in adult, but not in children. Again, it is coming back to the etiology. When you are talking about the pediatric, it is genetics. When the genetics is a predominant factor which is predisposing a particular disease, you are not expecting any change of incidence or prevalence of the disease. On the contrary, it is in the adult where it is alcohol and smoking is responsible, and there is data to suggest in North America over the years a 13% reduction of the smoking, and that might have contributed to reduction in the number of cases of chronic pancreatitis, but not in children. What about Indian scene? Do we have any prevalence data? We don't have. This is our publication of 320 cases of pancreatitis. What we have seen that 30% of them are chronic pancreatitis. This is the study from CMC Vellore, and what they have shown that chronic pancreatitis comprise of 2.5% of all pediatric gastroreflux. This is the busy center, and out of 3,887 all pediatric gastro cases, they got 99 to 2.5%. So though it is less common, chronic pancreatitis in children than in adults, but it is a substantial number we do get in referral center. Now coming to the clinical feature, what is the difference of clinical features between the Western CP and Indian CP? I've taken this INSPIRE study group 146 cases compared with our data of 146, 56, and CMC Vellore 99 cases. So if you see the mean age or median age, it is the older children, not very young, 10 years, 13 years, 15 years. Though in the West, it is a 57% female, but in India, we get predominantly male. Pain, which is there in almost all cases of chronic pancreatitis in children, we hardly see a case without pain. But what is the interesting part is that episodic pain. Most of this chronic pancreatitis in our setup we get, they comes with recurrent episode of pain. So here comes the importance of looking for a cause in recurrent acute. Many of them are diagnosed as recurrent acute. Now you start looking for it seriously to look for CP, you will get CP. Because 94% of our chronic pancreatitis patients, they have presentation like that of acute recurrent. Continuous pain is, though it is common in the West, but not in our setup. Pancreatic insufficiency is seen not so commonly. Exocrine insufficiency is around 10% of the cases. So Western studies say 26%. Endocrine is around 5%. But what is the main difference between that American and European study and Indian is the calcification. We get more of a chronic calcific pancreatitis as the non-calcific, whether this is a spectrum of the same disease that we are picking them up late when they develop calcification, or in true sense they are a different entity that we don't know, but the calcification is definitely almost half of our cases of calcification than just 14% in the West. Now coming to the management issue, as I said, the pain is the main problem. More than 90% of children, they come with the pain. So obviously you need to give analgesic. We always prefer to avoid opiate because of addiction. So we'll try with NSAID like paracetamol or ibuprofen. If it doesn't work, then only you go for opioid. Endotherapy plays definitive role when it is indicated. It is not that all children with chronic pancreatitis will merit for endotherapy. If you have a child who has the obstructed system, means there is a stricture or stone with the upstream dilatation, definitely endotherapy helps. And how effective it is? we have a large study published from Asian Institute of Gastroenterology. JAI has published this study in 2014 of 143 chronic pancreatitis. They have used the endotherapy, and what they have shown, though the follow-up was short, just 13 months, almost two-thirds of the cases showed complete response of pain after endotherapy. If you compare to the adult, with a huge database, it's a multicentric study from Germany of 8 centers, and with the follow-up of 2 to 12 years, they have done endotherapy for chronic pancreatitis, 1,000 adults. And you see the indication, predominantly it is a stricture, 47%, stone 18%, combination of stricture and stone in 32%. And on follow-up, what they have shown, the 25%, 24% require surgery, 16% are still on therapy, and rest 60% has completed therapy. And the successful outcome was shown in, again, 65% in the long term. So endotherapy, when indicated, it is useful. Like in adult, almost two-thirds of the cases we get the good response. Yes, surgery plays a definitive role in the management of chronic pancreatitis. In children, usual goal is pancreatic preserving surgery, means drainage surgery, but a group of people in America especially, they are in favor of doing total pancreatectomy with islet autologous transplantation. This is especially those cases who are refractory, means they have intractable pain, not responding to your conservative medical therapy or endotherapy, they need to go for this. And in the long-term result over 10 years is shown 80% are pain-free and 40% off insulin. Nutritional assessment, which has been shown that almost the resting energy expenditure in chronic pancreatitis 30 to 50% more than general people. So they do need extra calorie, but right now there is no indication of giving extra calorie, but we need to monitor these kids with their anthropometry, weight, height, BMI, every 3 to 6 months. And this is the recommendation of SPEGAN, NESPEGAN, North American Society and European Society of Pediatric Gastroenterology guideline on nutrition in pancreatitis. And if you see our data, wasting means this, their weight is less than 3 standard deviation is almost 36% of our children with chronic pancreatitis. 22% are stunted, and Velo study show 28%, and Velo study show low BMI in children is 50%. So they do have compromised nutrition. We need to look at it. Even if they don't have, we need to monitor every 3 to 6 months. What about the fat soluble vitamin? Vitamin A, D, E. This is a study which was done in Minnesota and just published in the September of this year. Of 100 children with chronic pancreatitis, they assess their fat soluble vitamin level before this total pancreatectomy, and they have shown 17% have low E and 22% low vitamin D despite their therapy. So we need to look at them yearly estimation of ADE level, and if there is deficient, we need to do therapy. What about the bone health doing by BMT? Routinely it is not indicated, but if the child has persistently low vitamin D or there is a history of fracture, especially if there is a vertebra, hip or wrist, then we should go for bone mineral densitometry to look for bone health. Exocrine insufficiency, it is not so common in our series, but over the time they do develop exocrine, so we need to monitor their exocrine function every 6 to 12 months by doing the fecal elastase or 72 hours fecal fat. And if you get the pancreatic insufficiency, this is the guideline how to use that pancreatic enzyme replacement therapy in children. If it is less than 4 years, you need to give lipase at a dose of 500 to 2,500 units per kg per meal, and half the dose for snacks. But remember, we should not cost 10,000 per kg per day, because the risk of fibrosing polyneuropathy increases with the we start giving very high dose of lipase. Endocrine insufficiency, 6 to 12 months, we need to monitor their fasting blood sugar and HbA1c to detect the exocrine endocrine insufficiency. So to conclude, pediatric chronic pancreatitis is not so uncommon. We have documented that predisposing factor is a gene, and that gene is there in India. So we are supposed to get chronic pancreatitis. genetic mutation plays a very important role in the pathogenesis of pediatric CP. Almost 75% of CP, they have some of the other genetic mutation. Genetic testing, I think might help in idiopathic acute and recurrent acute pancreatitis to find out their outcome in the long run. Are they going to develop CP or not? And if you get the mutation in idiopathic RAP or AP, then we should go for lifestyle modification, avoiding alcohol, smoking, etc. And we need to monitor these children for their nutrition, for exocrine endocrine insufficiency, and fat soluble vitamin status. Thanks for your patience.
Thank you, Professor Podar, for a comprehensive overview of pediatric pancreatitis. I know it's a very big topic, and there were a lot of things to cover. I think we can take questions for you, sir, at the end of this talk at the same time. So I would now like to welcome the next speaker, Professor Bharadwaj, who is a professor at the School of Biotechnology at Jawaharlal Nehru University. He's a professor of systems at the genomic lab there. And he's going to talk about a very, very interesting topic that everybody wants to know. That is the genetics of chronic pancreatitis in the Indian population. So with this, I would like to invite Professor Bharadwaj for his talk, sir.
Let me also add that Doyapan is the only real scientist among all of us. We are all fake. He is the real scientist. And he is someone actually who has shown new genetic mutations in polymorphism in diabetes and also now in chronic pancreatitis. So he is one of the best known geneticists that at least I know. So thank you very much, Dr. Bharadwaj, for joining in and agreeing to give this talk. Thank you. Over to you.
Thank you, Pramod, for that nice introduction. Actually, in India, I am seeing that you are the best physician scientist. See that I always think that if you would not get that patient burden, what wonder you can do. Thank you, everybody, giving me the chance. See, last 20 years, I'm doing this metabolic disease, type 2 diabetes. Somehow, Pramod thought that I would be some help in this chronic pancreatitis understanding. So we started. So basically from that one question somebody asked before going to that whether it's a one gene mutation. No, it's not a monogenetic disease. Is a problem is like that. This disease doesn't follow Mendelian pathway. So biology is difficult and these are multigenic. So before going to all of those things, I will show the major genes what we replicated. One paper we will discuss. This I will not bother you to go because you are all the physicians. So it's absolutely prudent to tell you all of these things. But one thing is like that, whatever the disease we may say, except accident and other, they are all caused by genes, because our understanding of these diseases starting from the phenomena or observation, and then we start doing cell biology or biochemistry, we want to do some therapeutic target like that. But it would be better if it starts from the gene, that if we know what are the gene involved and what their biology are there, and then everyone can use that and it will be a wonderful world. So why you are not understanding gene? Because genes are always need environmental interaction, whether it's a nutritional interaction or other some secretional interaction, protein interaction in the body. So if we do not know the environment, that is our bait, then we cannot get the gene. So slowly those genes are coming, and multifactorial gene absolutely are not the candidate gene business, because candidate genes are those where we understand the biology. So if we have to get those all unknowns, then we'll have to go with some unbiased approach. But I will not go to that, because some unbiased approach we will show that how it is prudent in Indian scenario. So this is a replication study of these pancreatitic GWAS in Indian population. So we know that this genetic susceptibility, this is pinpointed because my previous speaker made my life easier. Professor Poddar shows that what is the underlying genetics susceptibility, and based on that, physicians are phenotyping. So I will try to talk about the biology after this discovery and how we can say, like those some of those talk. One of the talk you are talking about the cofactor as the gallstone and other. Those are also genetics. If you forget these pancreatitis genetics, if you think there is a certain mutation which is responsible for that gallbladder inflammation or deformity, and now that deformity is causing biological problem, and then you are precipitating the pathology. So actually underlying mechanism starts with a defective gene. This risk susceptibility of the chronic pancreatitis today cannot be fully explained because of the all known genetic mutations. And there are other lots of genes involved. And it is obvious in these multiplex disorders that more than genes are involved because they are all of these genes effects are in small. Mainly we know that genes which are responsible today for this CP biology are PRSS1, SPINK1, CFTR, chymotrypsin C, CPA1, CEL. So these are the genes. On this background, one paper came, there is that genomoid variation studies. What is the genomoid variation studies? That is totally different than candidate genes. So among the mutations, main 90% mutations are the point mutation. That means it changes a nucleotide and that changes within that coding region. So it changes amino acids. So in the protein, that structural conformity is changing. And if the mutation is near the active site of the enzyme cannot properly work, but there may be some residual activities, and residual activities absence or present, that can be a beautiful prognosis to physician's hand, and then they can understand the severity of the disease, of the mild nature of the disease. Here to mention that one thing that you people are talking about the autoimmunity and autoimmune diseases. The moment we think about the autoimmunity in the classical sense, we think that the antibody response is unchecked. But here I will tell, particularly this disease, when I see all of those candidate genes, you will see that many of these genes involving either protease or protease inhibitor. These proteases are the devastating things. In our plasma, there are lots of proteases, complement proteases or coagulation proteases. These proteases are there, and all of them are in inactive form and the zymogen form. Because if they are in active form, that will be devastation in the body. Body couldn't tolerate that. So only in the during time that when it needs, that zymogen is activated, it works, and then it again vanishes. So now you imagine in this kind of gene are checked also by inhibitors. So if inhibitors have the problem of the serine protease, which is here in the SPINK1 or another inhibitors also I thought I saw is a Kajal type inhibitor, then what you are getting? Unchecked protease, and near about all of those tissue, that protease will start cutting, and it is full of pathology. So here we are seeing that lots of proteases, either they are having problem or the inhibitors having problem. Many times proteases having problem can be a little protective. So that kind of, you think that devastation will also mimic a little bit of those autoimmune diseases. Here what I'm going to show our data, because this project is actually to say is Pramod's project, because without Pramod I would not come in the pancreatitis field and I will start. So it started with the Pramod, and in every step he's involved. And so this paper come sometimes in 2012, that Whitcomb started a pancreatitis GWAS. What is the GWAS? Now you think about all of those point mutations of that single nucleotide polymorphism. Instead of 1, 2, 10, we are taking say 1 million single nucleotide polymorphism in one slide. And then instead of testing 400, 500 case by control, we used to test minimum 1,000. So now you see the enormous data point, then with the high computational help, the same t-test and same all of those statistical tests, it gives us the option now. When we are starting with the 1 million SNPs, then there will be SNPs which are unknown WARF. That means those genes not even functionally known. There will be genes which already biology known, but that biology, it will be very difficult for you to relate with the pancreatitis. So it's an unbiased approach. So it will bring out something, then we'll have to build up the hypothesis and go for the biology. So here with this genome-wide association studies, Whitcomb's group find out some new variations. Some variations which we'll find that is a totally new, that X-linked. That means there are tendencies in some of those chronic pancreatitis you are finding is a male dominated. So now we can understand that biology I will tell you a little later, that is CLDN2 and MORC4, these are X-linked. And obviously this PRSS1 and PRSS2 loci people are knowing earlier. So we tested those things. These various studies revealed there are already we know Indian population that we are a little genetically different than other population, because another thing is like that to do genetic studies in Indian population is better in that sense that diseases will also be plenty, and not only that endogamy, because still even in the urban area, if you start a Sunday newspaper, you will find that bride needed, grooms needed, and they will ask that Khatri marries Khatri, this Sikh marries Sikhs, this Bengali Brahmin will looking for Bengali Brahmin. So automatically this is a genetical mouse situation. So it will give you less noise to find out gene. So this kind of population is always favorable for genetic fishing. So all of those genes associated with the disorder in other population, that definitely we need to be evaluated, because so far in this population, one of the major discovery, it's not discovery, but everybody was knowing that one of the major gene here is the SPINK1, and the SPINK1, that particular N34S mutation, that is a mutation, is very, very much important. So we started with those. And in the study design, we chosen 519 patients that with the chronic pancreatitis, and you see there are divide with those 434 idiopathic and alcoholic 85, and 1288 healthy controls. And these diagnosis of these, I am not going into detail because they are all coming from the physician's clinic after beautifully phenotype, because all of the essence of finding gene lies in the wonderful gold standard phenotype. The phenotype will be better, so they will be much more homogeneous, and the gene, finding the gene who are responsible will be much better. And these are all of our control. Since we are working in this North India, so these are Indo-European ethnicity. Here to mention, in India, there are lots of different groups of population, but there are only major 4 groups. One is Indo-European ethnicity. They live in the northern side of the India, and they are here. These are linguistic based. And Dravidian ethnicity, they live in the southern part of India. And third is the Tibeto-Burman ethnicity. They live in the Himalayan border of India and also Northeast. And fourth is the Australo-Asiatic. Those are the most ancient people. They live in the middle part of the India, Madhya Pradesh, those area in the tribal belt. So entire of our work in this mainly constituted with the Indo-European ethnicity population. So we chosen those, whatever in that paper said, those, there are 9 SNPs, and these SNPs are in PRS1 and 2 and TNFR of this receptor gene. There is anti-PAP, there is MAMLI1, and this CLDN2, MORC4. There are 3 SNPs and 2 SNPs, and these are X-linked. So then we tested in that also in that sequence mass array system, and that controls where genotype already, we have the control data already we have in the Illumina platform. And these are our men women ratio, because whenever you are doing this kind of studies, just to have less noise, we need to check everything in this case control studies are more or less matched. So this is the number, total number is 1288, and 688 and 600, this is the male versus females. And among that chronic pancreatitis idiopathic, there are 434. They are substantial number, because since you have already presented lots of studies, and none of these studies, when we are doing, not from India, from abroad also, have this much studies, 500 or 400 cases, and 3 times more controls. And some percentages are smoking, and somebody chewing tobacco also, and there are lots of alcohol consumption. And specifically in our society, this alcoholic consumption mainly toward by males, so it is always will be biased with the male side, but that has nothing to do with the real biology, because you are not giving chance of these interactions. And most of these alcoholic or smoking related genes, whatever is coming, it's not environmental. It's an environmental and gene interaction. Suppose there are mutations, it is true, there are mutations for lung cancer. Maybe I have that particular lethal mutations in my lungs also, but I do not smoke. So I am not giving the chance of the interactions of that particular gene to precipitate the pathology. So I will never expect the disease. And this is a true thing, because you are physicians, you know there is a disease. I'm going to tell you this smoking thing and alcohol thing. That is that alpha antithrombin, alpha 1 antithrombin deficiency. If that deficiency happens, that is then you are having COPD-like syndrome and everything. But particularly they showed that there is a mutation. That mutation is a glue change to lysine in certain amino acids. If you have that mutations, then smokers and non-smokers, that prognosis is totally different. And they showed by the biology what is happening on if you are a smoker, and if you smoke, that smoking oxidized one particular amino acid methionine in exposed position, and that's why this pathology is coming out. So when you are drinking alcohol, that if you have that particular mutation in that protein, only then it will precipitate. Otherwise, there are thousands of alcoholic people, they will never show up pancreatitis. They may die with the cirrhosis, that's a different way. So our results, when we take the total 500 and normal total 1288 control, then we saw that among those things, PRSS1 is very significant in our populations. Actually, most of them are significant. And odds ratio, you'll see that odds ratio is that many times than normal is the risk. That means when I'm seeing that 1.72, it's in respect to normal, that this guy has 1.72 times more chance of having the disease. So you see there are two protective variations also in our population. This is PRSS1 and PRSS2. It is obvious, I told that this is the enzyme. So this is the protease. If there is any mutation in the protease, that protease activity will be less. And here protease activity less means is a less damage. That is exactly opposite to the SPINK1. SPINK1 is controlling the protease, and when SPINK1 has the mutation, it cannot control the protease, then protease is becoming rowdy and chewing up all of those protein molecules nearby, and you are getting those histological difficulties there. And when we tested these things, this association with only chronic pancreatitis, we remove the alcoholic pancreatitis, and then also finding that all of those SNPs or genes are coming very strong associated in our population. And when we tested with only alcoholic pancreatitis, those 85 versus 1288, then also we see all of them are standing. What does it mean? That means that these ACPs, also, or the chronic pancreatitis only who are not alcoholic pancreatitis, they carry more or less the same gene. But those genes, their mutations may be in different sites. That alcohol during their biochemical metabolism is precipitating the disease in that one way, maybe it is more severe. And then we tested all of those alcohol or your smoking variation, how they affect. And we showed that those alcohol and smoking both are affecting in sometimes, specifically in case of this Claudin 2 and MORC2, these alcohol or smoking are alcohol is affecting much more. And there is not that much more effect of smoking when we perform the same statistical test, with all of those same SNPs. So alcohol has a direct role in biochemical role with this kind of mutations in the body. And when we are testing that whether, because these are 9 SNPs, so every SNP, every point, there are 2 alleles, and those 2 alleles, we tested this, whatever you are talking, that's 2 mutations together, 3 mutations together, 4 mutations together. We see with those allele doses, and this your risk is increasing. And when you have 11 to 13 alleles together, or more than 13 alleles together, that your risk increase from more than 1 to more than 5%. It is obviously because then you're getting those small effect together, and which is showing a cloud effect, that individuals with 13 or more risk alleles, they carried 7.17 fold risk that compared to the individuals with 5 or less risk alleles. But significantly, that when you are taking only one, then you are finding that is only 1.2 fold risk than the normal one. So this is, we published quite a few years back in the PLOS. Now, how it will affect you, that how these genetics will affect your work or help you. Like those, what we are talking about, those general medicine today, most of them based by some radiological assay or physiological assay, biochemical assay, but more or less those observational assays. Then you are getting assumed same risk, same dose, same response. But if we are going to those genetic route, then this can determine the different risk that help you to know the beforehand what will be the prognosis. It can help you to phenotype better, and it can help you that 2 groups or more to treat them better. How it works? If you see this allelic, that how many mutations in the same genes are there. If you see, and the relative risk in this side, that if you have the protective, that there are any mutation has 2 alleles. One is your major allele and one is minor allele. And most of the time in the population, the minor allele is responsible for this problem. And if we see that minor allele, the major allele are homozygous, that means both are major allele, then you are saying that mild risk. But when you are seeing those both of the, that means 2 mutations are coming in the same gene, then you are finding the risk is high. So it will give you that one other tool which is very important to see the prognosis beforehand. So you can divide them along with those mild risk, moderate risk, or major risk, or severe risk. Like those, when we are talking about those total patient group, the same diagnosis, same prescriptions. But now when we are helping these genetics, with the help of genetics, when we are differing them, then we can identify gene markers, and we know that whether the drugs will be toxic or beneficial, or drug will be toxic but not beneficial in the 4 or 5 groups. And then we will make better risk prediction, and we can also go for the better targeted personalized therapy. But beforehand, we'll have to understand what those particular genes are doing, what are the major applications, and how they will do. Here to mention that when we are talking about the Claudin 2, that is that X-link, what is the biology of the Claudin 2? That can give you an idea that what kind of medicine you are going to use. Actually, Claudin 2, there are some biological studies not associated with the pancreatitis, but Claudin 2 shows that this molecule stays, that you know that inside the body, any tissue, there are lots of cells, and cells are not overlapping. They stay side by side and tightly connected. And in this connection, that called tight junction, within that there are lots of proteins. They help those cells to stay together. And Claudin 2 is one of the promoter, one of the major gene in the tight junction. Not only that, this is a tight junction protein. So obviously, if there is any mutation in Claudin 2, that those cell that binding will be loose. Not only that, it is also shown that this Claudin 2 has a promoter which has a NF-kappa B binding site. Now, many a times you are telling that whether this is that chronic pancreatitis or acute pancreatitis, or whether it is going towards the malignancies, cancer. So now you understand this Claudin 2, in the protein, there is a signature of NF-kappa B oncogenic binding site, the transcription factor binding site. So now maybe it works in that way, maybe, because this is speculative until and unless we show doing experimentation, but it is clear that it has a NF-kappa B binding site. So now, if we get this claudin 2 mutations and we in the binding site, if we see the binding site mutations, then we can think that depending upon the mutation, whether this patient will go towards this malignancy or not, because many chronic pancreatitis, though the phenotype will be the same, will have different gene, different mutation. So it is explainable a little bit that why some of those chronic pancreatitis patients ending up later in the malignancy, because claudin 2 has that purpose. Also, there is another gene which we are talking about, that is that MORC4, which is also X-linked. And you know what is the MORC4? MORC4 is a ubiquitous, that every tissues are having MORC4. That MORC4 biology is suggestive that it is a chromatin modification. What is chromatin modification? Because in our body, the genes are everywhere, same genes, but only in liver those clotting factors are synthesized. Only in liver those complementing factors are synthesized. Only in pancreas insulin is synthesized. Insulin cannot be synthesized in our skeletal muscle, but genes are everywhere. Those are by different mechanisms, they are silent, if not in the specific tissue other than the housekeeping genes. Now you understand that all of those chromatin material are packed tightly in the body with the nucleosomes. And the nucleosomal positions, we know there are 6 antibodies are available. With that, we can tell by precipitating that whether that is the open region and closed region. When it is synthesizing, it must be in the open region so that polymerase can run. And when it is tight, that means it is closed, it is inactive. So this chromatin modification, these kind of genes are helping, dictating during the time that you open up. So this side will translate these proteins. Our other protein are telling you closed up, then this is not the time of the transcription. So this kind of biology will have a direct meaning to your practice. So like those prognosis, we can know from those mutations whether those medications have those prognosis, whether this patient will be benefited or whether this patient will not be benefited. So this is the same thing. I'm not going into the detail because these are already a little bit of pharmacogenetics, that whether you know that particular drug will respond or not, or it will respond. So I will actually, this is my last slide, that depending the DNA mutation and variation, it will help you to manage the disease. It will help you to understand the phenotype. You will understand the outcome beforehand, and it will help you beforehand to know that medication what you are getting, whether that will work or not. So these are the collaborators, because with Pramod it started. Without that it cannot be started. And I am seeing some of the faces that I never met, but Dr. Shabir Mahindra, Dr. Khonis Das, Dr. Surinder Rana, Dr. Deepak Bhashin, they are all involved in these studies. And Saurav and Ololavo, these are the 2 statisticians. One is in Indian Statistical Institute and NIBG Calcutta. And these are my laboratory. Most of them are already vanished in the other side of the Atlantic. And we are quite well with the financial support.
Thank you, Professor Bharadwaj. That was a most interesting talk about a very, very important topic. Garg sir, should I start with some questions now, or would you like to comment on the genetics part?
No, I think we can take questions. I'd just like to thank Dr. Bharadwaj and Ujjwal for giving excellent talks, which are very illuminating. So I think you can please start with the questions.
Okay, the first question is for Professor Podar. Question is, sir, what is the incidence of pancreatic ascites in children in chronic pancreatitis? Is it common or is it seen commonly?
Pancreatic ascites, we don't have any particular figure that how many out of how many we got. It is seen. It is seen, but most of the time pancreatic ascites in children is in the setting of acute pancreatitis or post-traumatic pancreatitis. In the setting of chronic pancreatitis, it is not so common.
Okay. The next question is, why is
there more calcification in Indian children?
It's a very interesting question. When we publish our paper, then this one of the reviewer asked for it. Is it a spectrum of the same disease, like what we are diagnosing chronic pancreatitis? Probably it was the late stage, and that's why you are getting more calcification. Or Indian variant of chronic pancreatitis, a distinct entity, we don't know. If you go see the paper from the south, the calcification is universal, 70 to 80%. Whether this is the so-called tropical calcific pancreatitis or with the same chronic pancreatitis we are diagnosing late, that we don't know.
Sir, the next question is, if a child has diabetes, endocrine insufficiency, but no exocrine insufficiency in chronic pancreatitis, will pancreatic enzyme replacement therapy help in this case?
Very interesting question. If you see the sequence of events, that exocrine insufficiency comes before the endocrine. So most of the kids who are having endocrine insufficiency is likely to have exocrine, but if you have documented no exocrine insufficiency, there is no role of giving PARP therapy.
And
having said that, Rohan, can I add to basically our technique of documenting exocrine insufficiency is important. We need to do either fecal elastase or the 72 hours fecal fat excretion. Just doing that staining of the stool is not good enough. Sudan stain is not good enough.
Sir, another question on pancreatic enzymes in children. Should we prescribe them just for pain, even when there is no exocrine insufficiency?
See, this is a good question, and this is the malpractice going on all over the country. Any patient diagnosed whether acute, recurrent acute, or chronic, they are prescribed with pain. So I don't think there is any basis. So there is the two things. One is what you are treating. If you treat the exocrine insufficiency, you can use the preparation which are available, coated preparation. But if you want to use it for pain, you need the uncoated preparation, which is not available in India. And there is no concrete data to say that pancreatic enzyme therapy helps in the pain. We should not prescribe enzyme therapy if there is no insufficiency with this enteric-coated preparation.
Sir, what is the role of antioxidants in the progression of chronic pancreatitis in children?
Question, and the promote study has shown it reduces the pain, but as far as the disease progression, does it halt the progression? We don't have any concrete data. We have also done one study in our department. It shows some reduction in pain, but I don't think anybody has said that antioxidant therapy halts the disease progression.
Thank you, sir. I'll come back to you with a couple of questions. I'll just go to Professor Bharadwaj now. Sir, there is a question that why is your the PRSS1 mutation showing an inverse relationship with CP in your data? Is that an accurate question? Or?
See, there are two things. One is the single nucleotide polymorphism, another is the mutations. So we have tested with the Whitcomb's paper the particular single nucleotide polymorphism that probably is not carrying that what is the PRSS1 mutations in this population people are seeing. So it is obviously that whatever in the Whitcomb's paper is showing, that is that particular SNP is carrying the protective this thing. It is being shown that it gives the protection, but that SNP identification is the first thing. Second thing is that we need to sequence that area to find out the mutation and then go. SNP works in that way that if I take case and control, the particular SNP will be 65% in the case or maybe 40% in the control. But when you are going from the SNP to that SPINK1 mutation, then you will find that all of those patients will have that mutations and none of these control will have the mutation. So, so that's the difference. So that is that population specific way, but in this PRS11, we are not going to do the fine mapping and other, since we didn't mention it here because we finished our own GWAS that is totally unknown with almost 4,500 samples, and that we are doing fine mapping and functional biology on them. That maybe sometimes after the publications we will show that.
But this particular SNP is in the PRSS1, PRSS2 area, in that Hep block, and has been shown to be protective in
within that area.
American study also. So this is well known.
Thank you, sir. Next question for Professor Bharadwaj is there any association of mutation in pancreatitis associated genes and pancreatic cancer in the Indian population?
Yeah, that we cannot say, because to say that these are the things that you do base phenotyping and you give all of those patients who are from chronic pancreatitis end up in the pancreatic cancer. And with that questionnaire, if we get that people and then we do genetic analysis, then definitely we will identify those genes. But right now, I cannot say that. Maybe Pramod can say something.
So I think the issue here is, what are we talking about? Are we talking about germline mutations which predispose to pancreatitis, or are we talking about somatic mutations which occur in pancreatic cancer? So when we talk about germline mutations, we have shown that SPINK1 associated chronic pancreatitis is something that leads to pancreatic cancer in some of the patients. And similar data have come from another study in France, that SPINK1 associated chronic pancreatitis, something similar to PRSS1 associated hereditary pancreatitis, are significant risk factors for pancreatic cancer development.
Makes sense.
Somatic mutations in pancreatic cancer, these are, say, for example, KRAS and P62. These are the ones which occur in the cancer tissue itself.
Yeah, but makes sense, because both of the genes you are talking about, they are protease inhibitors. So uncontrolled proteases will give you devastation in one way or other. You don't never know, because they will chew up all of those proteins nearby.
Okay, I have some questions from myself, and I would like all three, Professor Podar, Professor Garg, and Professor Bharadwaj, to give us some insight into this. In children, should every child with more than one episode of acute pancreatitis, should all of them undergo a genetic test?
I attend first, Rohan. Yeah, see, it is not like that. Any patient with recurrent acute pancreatitis, your first target should be to identify a treatable cause. What are those treatable causes? Is mainly, so far we are discussing the obstructive cause, gallstone, microlith, or in children, any pancreatic malformation, this kind of things. So first you look for treatable cause. If you don't get any, then yes, I will suggest, my opinion, we should go for mutation study, because most of these cases we will have a mutation, and that will probably tell you that this chance of developing chronic pancreatitis is high.
Professor Bharadwaj, should we use the commercially available next generation sequence panels as a clinician? Should we use, are these good enough? Or should we then refer them to a clinical, a research study which is looking at the whole exome? What is the best diagnostic approach if you want to look at these genetic mutations in children and maybe in adults as a whole?
Children and adults, they carry the same mutations, maybe the environmental thing you are giving. But right now, that if you have to do it right now, then it is best to see only the one or two which are very well-known mutation, like SPINK1 or that PRSS1, which is all well-known. In near future, if our study shows something like those, that if we can, using all of those genes, can explain at least 50% or more, then that can be used for the clinician's background. But if I cannot explain even the 10% with those genes, that this case, then it is totally wastage of money, because these are costly studies. So if we get a panel, within that panel it explains more than 70% of those genetic causes, then that panel in a cheaper platform, then we can regularly use. But right now, we are not in that position. Maybe you can check that particular SPINK1, which is shown in Pramod's study, that 40%, more than 30% in the population in Pan India. show only one or two those mutations, but never the SNPs. Mutations are all or none. SNPs are everywhere.
But one of the problems is in testing for a panel of multiple genes and SNPs is that the effect size of most SNPs is very small. It's only about 1.5, 1.6, 1.7 order ratio. So even if you find some SNPs, it doesn't really mean that the child is having pancreatitis because of that. So outside of research studies today, if you look at multiple panels, I don't think it is going to serve any purpose. You can surely look for one or two genes, which is fine, SPINK1, CFTR. The other issue with genetic testing is that on one hand, it provides you something. Okay, there is a strong risk factor. But on the other hand, the patient and the family think, what next? There is nothing that we can offer as of today. There is some hope that for CFTR, now we may have something. So I think in the next 3, 4, 5 years, we can have some molecules to correct for CFTR deficiency. And that would be the time when we actually look for all the mutations CFTR. But as of now, I think outside of research setting, it may not be prudent to recommend genetic testing.
Yeah, absolutely, because this identification of the SNP is the first step. Next is the sequencing and find out the mutation. But those are the initial steps. Until and unless in the laboratory we show the biology, like those Claudin 2, if it is really in the tight junction making those cells tight together, then next step you can think about some chemical moieties as a drug which will help that Claudin, defective Claudin, to hold that those tissue cells together. Other than that, what is that Pramod is saying? Absolutely, that these things and they are not Mendelian. So it is not like that particular person, if as child will carry the same mutations. It is not like that hemophilia. So in that scenario, these are only very costly things until and unless you know the biology and know the therapeutic available related to that. So identification of gene is the very initial stage, because long way to go to show the biology and how it works.
Professor Arora has a comment or question.
Yeah, Dr. Bhardwaj, do we have any data that in patient with known etiology, say alcohol, gallstone, trauma, is it possible that those with underlying genetic mutation, be it PSSR or CFTR mutation, they are more likely to have pancreatitis, say with gallstones or alcohol?
I do not know the gallstone that Pramod can say, but we saw that in our GWAS, we did a GWAS, we didn't tell about all of those things, that is we got unknown and other, where we saw that when we segregate, initially we took all of those pancreatitis as a whole, that all alcoholic and chronic pancreatitis, because biology will be the same. I don't think that alcoholic pancreatitis will have a different biology than this one. Alcohol here is a modifier. Maybe some gene alcohol works oxidized or something, so that mutation behaving differently. But certainly with the alcoholic pancreatitis, myself and Pramod, we got certain genes which are coming much more pronounced as a whole than the chronic pancreatitis without alcohol. Yes. There are certain which can be modified by the alcohol. Yes, they are. But gallstone, I don't know.
Question for Professor Podar is that if you have a child who has recurrent acute pancreatitis or chronic pancreatitis early, and the parents ask that what is the prognosis long term, how often will he develop endocrine insufficiency or pancreatic cancer? How will we explain the long term outcomes for this child?
Typical question to answer. As we are discussing that this is all are related to the disease duration. At what stage of the disease we are looking for it. When we start with exocrine endocrine, it is just 5 to 10% when we diagnose. But in the long run, many of them, they are bound to develop exocrine. 50% will develop. And as far as the pancreatic cancer, everybody knows that chronic pancreatitis is a risk factor for pancreatic cancer, but we don't have any Indian data to say that what proportion of chronic pancreatitis is ultimately going to develop carcinoma. We know that in hereditary pancreatitis by 70 years of age, 50% develop pancreatic cancer. But avant-garde variety of chronic pancreatitis, we don't have any data.
And last question I'll take to Professor Garg and then hand over to him. Sir, in your large cohort of patients with pancreatitis, what proportion would you say that they started in childhood and how do they behave after they come to you?
So the patient that we see actually come when they are adults. So I have not more than 10 or 20 patients who came in before the age of 12. I think most of the patients will go to pediatrics. But the mean age of symptoms in our patients with chronic pancreatitis is around 18 years or so. And the mean age of diagnosis is about 24 years. So they have symptoms for quite some time before they come to us. But I'm sure in your series or Dr. Poddar series, the mean age would be what he showed was about 13 years in India, and I think it was 9 or 10 years in the Inspire cohort. So I think that depends on the clinic that you are in.
With that, I'd like to thank all the speakers for a wonderful talk and hand over to Professor Garg, sir, for the session. Thank you, sir.
So I'll ask Sudipta to propose a vote of thanks.
Thank you, sir. Thank you, everybody. I take this opportunity to thank everyone who's participated in this wonderful webinars. We had close to around 150 people who have logged in during the course of the webinar. We have, of course, there's a flood of webinars going on. We have multiple webinars on gastroenterology at the same time. And despite this, we have a wonderful attendance and a static attendance during this course. The videos of this webinars will be available on YouTube shortly. I take this opportunity to thank all the faculty, Professor Arora, Professor Rana, Professor Madhusudan for the sessions on autoimmune pancreatitis, my good friend Vikas for his talk on EUS in recurrent acute pancreatitis, Dr. Samir Mohindra for chairing the session on recurrent acute pancreatitis and putting forward these wonderful questions. Rohan for managing the session on pediatric and genetic. This is one of the most difficult sessions of pancreatitis. And of course, Dr. Ujjal Podar and Professor Dipan Bharadwaj. It was wonderful listening to both of you. At the end, I would like to thank Professor Garg for being the support system behind this entire program. Without his guidance, this program would not have happened. Thank you, sir. Thank you for being there always with us.
Thank you, Sudipta, for all the hard work that you're doing. I know that's difficult. Thank you very much.
Thank you so much, sir.
Good night.
Good night, sir.